Well, good morning and welcome to the 12th ever IAFP Resident Scholarly Works Virtual Summit. I'm Jenny Flynn, Vice President of Communications and Member Engagement, and I'll moderate today's webinar. Unless you're the presenting resident, please mute yourself. We have one and only one presentation during this first block. We also have two anonymous reviewers on board. During each presentation, the reviewers are assigned to provide scores and ask questions after the presenter finishes. You'll see they've been given fake names. A quick review of our process. The residents will have 15 minutes to present, and the clock starts when you begin speaking. You'll get a short 2-minute notice in the chat and verbally when you have 2 minutes left. If you pass 15 minutes, you'll be asked to end your presentation to keep us on schedule. Only the reviewers may ask questions, and you can either unmute yourself to ask your question or submit it during the chat. And I'll read the question aloud for the resident to answer. Now for the fun part, the required CME accreditation statement. The Illinois Academy of Family Physicians is accredited by the ACCME to provide continuing medical education for physicians. This academy activity is designated for a maximum of 2.75 PRA Category 1 credits if you are on for all of even 11 presentations. The IAFP adheres to the conflict of interest policy of the ACCME and the AMA. It's the policy of IAFP to ensure balance, independence, objectivity, and scientific rigor in all its education activities. All individuals in a position to control the content in our programs are expected to disclose any relationships they may have with commercial companies whose products or services may be mentioned so that participants may evaluate the objectivity of the presentations. In addition, any off-label, experimental, or investigational use of drugs or devices will be disclosed by the faculty. Only those participants who have no conflict of interest or agree to an identified resolution of the process prior to their participation were involved in this activity. All of our presenters did submit CME disclosure statements. For this block, Dr. Ashley Van Zant and myself, Jenny Flynn, have no relevant financial relationship or interest with a proprietary entity producing, marketing, reselling, or distributing healthcare goods or services. The CME credit link is also in the chat. Again, you can claim credit for all the presentations that you view. And just a reminder to everyone to submit your research. These presentations are ideal for Family Medicine Midwest, so please do send that along. And a couple quick reminders of upcoming events. A week from Friday is our annual White Sox game. Tickets are still available and you can get them right off our website. And there may be a couple seats left for our Chicago Sky game. They are going fast. That's not till August, but same thing. You can get your tickets through our website. And for both games, $10 of each ticket goes to support the foundation, which supports resident and student activities. Don't forget, IFP award season is going on. They're due July 1st. And here's how you can submit for any of these awards listed on your screen. And if you are still thinking ahead about what you want to be when you grow up and finish residency, our Career Center is available to you. The IFP's annual meeting is also November 9th in Naperville, and registration is open for that. And we have a meeting app. So a lot of things to get in there real quick. At that, I'm going to stop sharing my screen. And I'm going to introduce today's first presenter. Dr. Van Zant, you can go ahead and share your screen. And it's my pleasure to welcome from the Hinsdale Family Medicine Residency Program, Dr. Ashley Van Zant, with her completed project. Of course, our reviewers are Dr. Meredith Gray and Dr. Abby Lockhart. And Dr. Van Zant, good morning to you. Welcome. And the clock will start when you do. Good luck to you.
Thank you. Can everyone see my screen okay? Okay, perfect. My name is Ashley. I'm a resident from Hinsdale Family Medicine Program. And here's my presentation, Screening for Tobacco Use and Counseling Cessation at Hinsdale Family Medicine Clinic. So I have no disclosures. So my objectives for this was to assess how well patients at our clinic, which will be abbreviated HFMC, were screened for tobacco use and assess whether future work could be done to increase screening rates of tobacco cessation at our clinic. So tobacco use in the United States is still a very prevalent problem. About 28.3 million adults smoke cigarettes and 16 million people have a disease caused by smoking. Tobacco use has led to about 480,000 deaths per year. And there is a higher prevalence in men, households with lower incomes, and patients with Medicaid, which is a large population of what we see in our clinic, which is one of the reasons I was interested in this project. So here's a map of the prevalence in the United States. The darker colors are where there is a higher prevalence, and the lighter is a less of a prevalence. So Illinois is right in the middle. This data is a little bit older. I did see there was an update. So for the most recent data, the percentage in Illinois was about 14.5% rather than 15.5%. I took this from the IAFP article that goes over tobacco cessation. So they recommend when screening using the 5A framework. So 1 is to ask to screen everyone for tobacco use. 2 is advise, offering support. 3 is assess. So seeing if these patients are willing to quit, their level of dependence, if they've tried to quit before. 4 is assist, offering support and resources, and 5 is arrange. So making that plan and setting that quit date. There are also a few validated tests for nicotine dependence. I pulled this one up because I think it's quick and easy. It's a 2-question screening, and it could help you kind of learn with your patients of how much support they need when wanting to quit using tobacco. So the first question is, how soon after they wake up do they have their first cigarette? And then the second question is, how many cigarettes do they typically smoke per day? And this can give a sense of how much of a nicotine dependence that they have. There are a couple of treatment options, which I'm sure everyone is pretty familiar with already. Nicotine replacement therapy, which comes in different formulations: patch, gum, lozenge, inhaler, and nasal spray. And you can combine these with the treatment options below, or even with each other, such as using a long-acting controller like the patch with more of a short-acting, such as the inhaler for more of those acute cravings. Varenicline is also another treatment option. It's a partial agonist of some of the different receptors, so it reduces cravings and withdrawal symptoms, and it is the most effective FDA-approved pharmacotherapy. And then bupropion is another medication that can help reduce cravings by partially blocking some of the receptors as well. Combining behavioral strategies along with pharmacotherapy is the most effective treatment option. And using these treatments for greater than 12 weeks is associated with higher quit rates and lower relapse rates. I just wanted to add the USPSTF recommendations. So it is a grade A recommendation to screen all pregnant and non-pregnant adults for tobacco use. And then there's also that AAA screening in men 65 to 75 is a grade B. And then it's also a grade B for that low dose CT scan in adults 50 to 80 years of age who qualify as well. This was a CDC study that I looked at. So it looked at tobacco screening in hospital outpatient setting from 2005 to 2010. And this was published in 2015. And it did look at around 148,000 visits and their screening rates. So overall, about 65% of these patients were screened for tobacco use. It was higher at 71% in patients seen by their PCP. And it was a little bit lower if patients did not see their PCP or at other specialty and surgical clinics. What I thought was surprising is only 24% of those patients were offered tobacco cessation. So that was some sort of documentation about the tobacco use and counseling that had to be documented in the note. So the aim of my QI project is to identify patients listed as current tobacco users at our clinic and assess how well they were being screened for tobacco use. So to do this, I obtained a list of patients who were marked as currently using tobacco over the last 3 years. So from December 2019 to December 2022 is when I pulled the data for this project. So there were a total of 500 patients. About 23 patients were removed prior because they were either deceased, inactive in the clinic, or not seen within the last 3 years. I then completed a chart review to determine if the quality measure for tobacco screening was met. And the quality measure was considered met if the patient was screened for tobacco use and it was documented in the history section of the chart within the last 2 years. I then gave a presentation to our resident class about screening and counseling for tobacco cessation. Then I did a second chart review completed with patients seen after that presentation. So for about 7 months after I gave that presentation, I pulled the data. There were 275 patients that were seen and marked as using tobacco. And then I reviewed these 275 patients to see if they met the quality measure for tobacco screening. I then compared these two data sets to see if there was a difference. Here is my data that I found. So on the left is the pre-intervention data, and on the right is post-intervention. So when I looked at the quality measure for that pre-intervention group, I found that only 42.8% of those patients were meeting that quality measure. And this seemed very low to me. So I wanted to look into this further. So I did some further chart review. I looked through the visit notes from those patients to see if we were missing patients who actually should have met the quality measure. And I found that there were a lot of patients who we missed, who it was documented in the notes that they used tobacco, and a lot of times there was counseling also discussed, but it wasn't marked in the history tab, so it wasn't meeting that quality measure. So when I pulled these patients that we were missing, it actually went up to 65.6%, which was similar to that screening in the CDC study. I then looked at the post-intervention group from after I gave the presentation, and about 82.5% of these patients were screened and met that quality measure. I looked in to see if we were missing any patients like I did previously, and it did go up to 89.5%. So here is basically the same thing in graph format. So the left side shows that pre-intervention group and the right side that post-intervention group. And then that striped line shows when I added patients back in, because there was documentation in the notes about screening for tobacco use, but they just hadn't met that quality measure because of the documentation error. I then did a statistical analysis. So a two-tailed test was run between the two data sets. And I looked at the pre and post-intervention group. And then I also I did a second sort of data analysis when I included those patients who were missed, but actually screened. And they were statistically significant. So significantly more patients were screened for tobacco use in the post-intervention group with that 7 months worth of data compared to that pre-intervention group. But I do think there were several other factors that could have contributed to this difference as well. So during those 3 years of data, COVID-19 was also occurring, which I think may have affected some of the data. So office visits were often more limited at this time and often focused on acute issues. So screenings may not have been discussed as often. We were also doing a lot more telemedicine then as well. When I was looking through the data, a lot of times nurses and medical assistants are also screening for tobacco use. When we do the telemedicine visits, we just go right with talking with the patient. So we also kind of miss a step where screenings could have been missed. It was also 3 years worth of data versus 7 months. So that could sometimes make a difference as well. And what I think could have most made the difference is my study didn't account for any changes in the EMR that occurred over the last 3 years. It does look like, so we were on the EMR Athena when I did this project, and they do tend to update their quality measures at times, I noticed. And actually, when I finished the project, I noticed that they actually got rid of the quality measure for tobacco use. So they could have updated kind of criteria to meet the quality measure that I just didn't know about in that 3 years worth of data. So I'm wondering if that could have affected the data as well. So my study did differ from that CDC study, as I only looked at patients who were already labeled as using tobacco, is who I included in my study, and they looked at all adult patients. I also didn't assess the types of appointments patients were not up to date with, such as their annual well visit, which is another time we usually always make sure to screen for tobacco use. I also did not look at a pediatric population, and I didn't focus on vaping as well. So for some future steps and research, so overall, our clinic is screening more patients for tobacco use now compared to data over the last 3 years, which I think is great. And MAs, nurses, and physicians were all screening for tobacco use. So I think it's great to have those multiple layers of healthcare providers screening. I think some future direction could be creating a more standardized screening and a reminder tool for counseling for cessation when patients are using tobacco. And another area of future study could be determining how often screening patients converts to being prescribed pharmacotherapy or other types of intervention. So I'd just like to thank Dr. Kian. He's our Director of Research at our program, Marianne Harrelson, who helped with data extraction, and then Anne Impens, who helped with the statistical analysis, and then everyone at our clinic who helped me with this project as well. And here are my references. So thank you.
And we thank you also, Dr. Van Zandt. So at this time, I will ask our 2 reviewers to pose their questions based on what they saw.
I had a question. I mean, maybe something that you can further look into, but were you guys able to look if there was like a difference between screening rates between in-person visits versus like telemedicine visits, since there's that MA step that's missing?
I didn't look into that, but I think that would be a really good thing to do, especially because after I finished the project and I was reviewing everything, I was thinking that could have been a point that would have been good to look into.
Great. And then one more question. Is there like a protocol typically that like every MA needs to, you know, address tobacco cessation and document it in the history tab? Do you guys have that in your clinic?
When I talked to our nurses about it, she did say when they room the patients and get everyone in there, they are supposed to kind of, you know, update medications, see if there's any changes in history. And I believe they're supposed to ask as well. So I'm not sure if that's happening all the time or not, because that would be another good thing to look into and make sure that's updated, because that would definitely help with this as well. Yeah, they are supposed to ask though. I'm just not sure if it happens every time or not.
Okay, great. Thanks.
Okay, hi. Thank you for your questions, Dr. Gray. Those were 2 questions that I was gonna ask. But what I was going to ask is, it does sound like the screening rates increased after your intervention. My question was, again, kind of like this protocol, like you brought up, that usually medical assistants or nurses are the ones that are asking these questions. Were they included in your educational portion of your intervention?
So they were not at my presentation. I did afterwards send it out to all the like faculty and like clinic staff afterwards and in an email and kind of ran through some of the points that I talked about.
And then you kind of also addressed this with saying that then one of the next steps is to see if increased screening leads to increased intervention. Were you able to assess that at all in your current study?
I wasn't able to go through that yet, but I think that'd be a great kind of follow-up project to assess that further. Yeah, I just kind of stuck with just the screenings for my project, but I think there's so many directions that you could go with or add to for this.
Thank you for your answers.
Thank you so much for your presentation. If there are no further questions, then I will give my thanks to Dr. Van Zandt, Dr. Gray, and Dr. Lockhart for their time this morning. That's the one presentation for this block. So just to kind of put a bow on this block, I'll get the scores in the comments from our 2 reviewers electronically for all the presentations that we have today, and process all those and get the scores and comments back to each individual lead presenter, hopefully by the end of the day tomorrow. And you'll also get a link to the recording, so you'll be able to see it for yourself. And then we'll be back at 11:20 for the next block. So thank you to everyone. I'm going to pause the recording and reconvene at 11:20. Thanks so much. All right. Welcome back to the second block of our Resident Scholarly Works Virtual Summit from the IAFP. Unless you're the presenting resident, please mute yourself. Only the presenters should activate their cameras if they wish. We have 4 presentations in this block, and we have our anonymous reviewers on board. So here's how this will work. During each presentation, 2 of the reviewers are assigned to provide scores and to ask questions of the presenters after they finish. You will see they've been given names of TV show doctors. The residents will have 15 minutes to present, and the clock will begin when they begin speaking. You'll get a 2-minute notice in the chat and verbally. If you pass the 15-minute mark, you'll be asked to end your presentation to keep us on schedule. And then only our assigned reviewers may ask questions. Reviewers, you can either unmute yourself if you'd like to ask your question verbally, or submit your question in the chat at the bottom and I'll read it aloud. And now for the fun part. I won't read the whole thing because I did it in the first block, but the Illinois Academy of Family Physicians is accredited by the ACCME to provide continuing medical education for physicians. The Illinois Academy of Family Physicians designates this activity for a maximum of 2.75 AMA PRA Category 1 credits. For this event, all of our speakers did provide CME disclosures forms, and I can say that Dr. Nocito, Dr. Lawrence, Dr. Sadek, Dr. Sormento, Dr. Carter, and myself as staff disclosed no relevant financial relationship or interest with a proprietary entity producing, marketing, reselling, or distributing healthcare goods or services. So we are good to go there. And then for everyone who is observing as a physician, you can claim CME credit for every presentation that you view. Each one is worth 0.25 credits. And you can also request a certificate of participation if you don't need the CME credit yet. I'll put that link again in the chat, and that will do it. So with that being said, let me run through a couple other quick announcements. Don't forget, you can still take these research presentations and submit them as abstracts for the Family Medicine Midwest Conference. Those abstracts are being accepted through June 2nd. If you have a poster, those are being accepted until June 10th. And if you're looking for something fun to do, we have our annual fundraiser for our foundation a week from Friday at the White Sox game. You can get tickets online through our website. And then later on this summer, if you're interested, the Chicago Sky, we have a group of tickets there. Same thing, $10 of each ticket goes to our foundation. And this is also available off our website homepage and that QR code. It's also award season. So if you have someone you'd like to nominate for any of these awards listed on the left, the deadline is July 1st. The form is online and it's super easy to do. And if you're still looking for that next job, go to the IFP's Career Center. That's a great place. It's free for members and you can find the job you want or let the job that you should have find you. So with that being said, I'm going to stop sharing and introduce our first presenter for this block. I'd like to welcome Dr. Brian Nocito and his co-presenter, Dr. Glenn Lawrence from the Advent Hinsdale Family Medicine Residency Program. They're presenting their research in progress, and the reviewers for this presentation will be Drs. Mark Green and Dr. Natalie Manning. Dr. Nocito, are you all good?
Yes, I'm ready to share my slides.
Yeah, hit share your screen. I'll let you know when we can see it. All right, your slides are visible, and we wish you the best of luck. The clock will begin when you do. Good luck.
Okay, I'm just trying to figure out how to get this to actually present. There we go. Can everybody see that? Okay, next.
Yes.
All right, I'll let Dr. Lawrence start.
All right, so we studied or evaluated resuscitative efforts on patients in cardiopulmonary arrest. And our study was regarding code duration and all-cause mortality. We have no actual or potential conflicts of interest in relation to this program or presentation, and sadly, we have no financial interests otherwise or other relationships to disclose. So background, refresher, cardiac arrest is sudden loss of all heart activity. It's usually caused by arrhythmia, and our H's and T's, which include hypovolemia, hypoxia, hydrogen ions, meaning acidosis, hyper and hypokalemia, hypoglycemia, and hypothermia. T's being toxins, cardiac tamponade, tension pneumothorax, thrombosis, coronary and pulmonary, and trauma. Preceding symptoms may include fatigue, dizziness, nausea, chest pain, palpitations, and loss of consciousness. Risk factors include drug abuse, heart disease, family history, elevated blood pressure or cholesterol, and obesity. All right, so we are familiar with our ACLS algorithms. We'll get to that in just a second, but identification of an arrest, we look for loss of consciousness, such as a sudden fall. The individual will be apneic, pulseless, and unresponsive. So we should begin CPR immediately, call 911, grab an AED if outside the hospital, or hit the code button if in the hospital, and then follow our ACLS clinical guidelines. Now, a couple of notes on those guidelines. We want to make sure we're minimizing time when compressions are not occurring, because we want to continue to keep oxygen circulating to reduce the death of brain tissue and heart tissue as well. Another point that we wanted to discuss is that it might be better to administer those medications such as epinephrine at the beginning of a cycle of compressions to promote the circulation of that medication rather than just before a pulse check. However, there's no formal data that we have seen conveying this. Another note is if you are going to deliver a shock, unless the patient regains consciousness, starts moving spontaneously, immediately jump back into the next cycle of compressions, and the next pulse check or rhythm check should occur at the end of the next 2-minute cycle. Some interesting things that we found, if on UpToDate, it said that if ventricular tachycardia or ventricular fibrillation persists after at least one attempt at defibrillation and 2 minutes of treatment, epinephrine may be given. But if it's given prematurely, so before that 2 minutes following defibrillation, that has been associated with a decreased survival. Lastly, ROSC, so return of spontaneous circulation, does cause a rapid transport of carbon dioxide accumulated in tissues during the cardiac arrest to the lungs, and this can be detected as a sudden rise in end-tidal CO2. Therefore, a sudden rise in end-tidal CO2 may be the earliest indicator of ROSC during an arrest. All right, so some questions that we had is, how long should cardiopulmonary resuscitation last? Are there any factors which influence survival, such as the initial rhythm, the time of day, the age or sex of the patient, the code status, whether they're a chemical code, no compressions, things of that nature, any metabolic abnormalities such as pH and electrolytes, previous stent placement, valvular abnormalities, medications that the patient is on, such as pressors, whether an attending or resident was the one running the code. And then other questions include, what happens after the code if the patient achieves ROSC? Do they go to hospice, DNR, to an LTAC, acute rehab, to a SNF, home, and do they have a subsequent arrest? So our objectives were to evaluate correlation between code duration in cardiopulmonary arrest and all-cause mortality, to look for a relationship between pre-existing risk factors and patient characteristics on mortality during a code, to measure differences in mortality between patients with different code statuses, and to assess patient outcomes and discharge disposition for patients who survive ACLS. In terms of our methodology, we did a retrospective correlational study. In other words, we attempted to determine if there was an association between the data and survivability. We did a logistical regression of resuscitative efforts during cardiopulmonary arrest and mortality. meaning we looked at multiple factors to determine their influence on mortality. So co-duration, time of day, as we discussed earlier. We did a chi-square analysis of patient risk of categorical variables contributing to survival rates. So basically, this is an evaluation of non-continuous variables' effect on survival. And then one-way ANOVA tests and 2-sample t-tests evaluating for resuscitative duration mean values compared across factors of interest. An ANOVA being 2 sets of categorical variables being analyzed simultaneously. So an example would be survival outcomes related to age. So is a patient of a given age range more likely to go to a SNF, for example, following ROSC? And then paired 2-sample t-test checked for statistical significance. These are our criteria for data selection. Patients being 18 and older were included in the study, and cardiopulmonary arrest during hospitalization on our med-surg, PCU, or ICU floors at the Advent Health Hinsdale campus between 2019 and 2022. Our exclusion criteria were resuscitative efforts that started initially and then stopped due to DNR status. If the code duration was less than 20 minutes, resuscitative efforts stopped prior to 10 minutes due to surrogate decision, and inability to assess code duration through review of medical records.
Okay, so I'm going to take over with regarding the results themselves. The primary outcome, our first and most important one, was pretty consistent with other studies that evaluated the overall survivability of ACLS. It's approximately 60% as found at our hospital, which is very consistent with what we've seen at other hospitals and other inpatient settings. This is statistically improved and significant compared to the estimated somewhere between 10 and 15% for BLS only protocol for a patient who arrests primarily in the field, which is good to know that ACLS does in fact what we expect it to do. The other major important thing that we discovered was the statistical significance of code duration for patients who achieved ROSC versus those who did not. This is a box and whisker plot showing 25th, 50th, 70th percentiles, as well as average values. I really don't even need to explain this because I think everybody can see that the 75th percentile for code duration of patients who survived is actually less than the 25th percentile for patients who expired. And you can see also that as the patient's code duration increases in time, the odds of expiration increase significantly. There's roughly an inflection point at about the 10-minute mark from our estimates. But you can see that as we get past 20 minutes, for the most part, patient survivability continues to decrease. Something of note is when we evaluated the initial rhythm on rest, that it is very, very important if the patient is in a shockable rhythm, VTAC or VFib, that they get shocked very quickly. The statistical improvement in mortality showed that I think 87% approximately of all patients who got immediate shock from a VTAC and VFib achieved ROSC very quickly afterwards, in contrast to asystole and PEA, which there's no difference between the two. This emphasizes the importance of shocking when a patient is in a shockable rhythm early. In fact, ACLS has recently adjusted their protocol to emphasize shocking for shockable rhythms quickly as a consequence. Something else we evaluated was that partial code status patients who elect not to get a full ACLS protocol, either no compressions, no shocks, things of that nature. For clarification on the partial code survivability, there were only 2 scenarios for patients who survived with a partial code status. One patient who elected for no shocks, but was not in a shockable rhythm at any time and managed to survive ACLS protocol. So they technically survived while partial code. The other, which I believe was a patient who received no compressions. They got 1 round of epinephrine, and then 5 seconds later, a pulse was palpated. Based on our knowledge of pharmacology and distribution through body systems, the questionable nature of if this was a true code is suspect, but regardless, we found that effectively a patient who is partial code is, practically speaking, a patient who is DNR. Something else that we evaluated was a common misconception by providers that the age of a patient is likely to affect survival rates, that patients who are older are not going to achieve ROSC. We did not find any statistical significance for this whatsoever, and surprisingly so. This is a graph that's just demonstrating what the overall survival outcome is for patients who do go into cardiac arrest and then survive. It's unfortunately very dismal. Approximately a third of patients who go into arrest will unfortunately arrest a second time in the near future. And a large majority of the patients are quickly switched over to hospice or DNR status and subsequently pass as a result later on. There is a portion, approximately 25% of all patients, though, or sorry, 20% of all patients, though, who will survive and be transferred to other forms of medical care, such as rehab, SNF, LTAC, or actually be even discharged home. This is a graph demonstrating the age separation of those discharge outcomes. There is no statistical significance found between various age groups and their overall discharge outcomes, so we cannot safely say that a patient being older is more likely to go into subsequent rest or rehab or anything of that nature, as far as we could identify. Another evaluation we did was the common notion that resident physicians are less experienced than senior physicians at running codes, and there would be a significant change in mortality. We had limited data in this case, since most of the codes in this hospital are run by residents, but we had enough data to support that there is no statistical significance between resident physicians and any other providers who served as code leader. This project is going to continue, though, so we'll have more data on this in the future. We also evaluated if there was a specific time of day, possibly nursing shift change or other factors that would influence patients going into cardiac arrest at one time or another. Specifically, I've highlighted here, this is the time when the shift changes occur for nursing. We did not find any statistical significance in this situation either. If a patient is going to go into arrest, they're going to go into arrest, and it doesn't seem to have a drastic influence regarding time. This is just a list of all of the other various risk factors. I'm not going to go over each one of these things individually, but these are what we evaluated to see if there was any significant change regarding mortality when we were evaluating these risk factors. A lot of these were generated by talking with various specialists from cardiology, pulmonology, gastroenterology, and so forth. Surprisingly, all of these had no impact on survival, including receiving CPR previously during the admission, if they were recently admitted, if there was a documentation for poor prognosis from specialists, or anything else as listed.
So regarding our conclusions, we obtained ROSC in 60% of cardiac arrests. Our average duration of successful codes was 9.7 minutes, significantly different than unsuccessful codes, 23.9 minutes on average. Our evaluated variables do not impact survival, with the exceptions being the initial rhythm, IV drug use prior to arrival, and arrest rather, and code status. 89+% of patients achieve ROSC within 20 minutes. Defibrillation, when appropriate, does increase survival. Partial codes cause an increase in mortality. Mortality is not affected by prior CPR during admission, age, renal or hepatic failure, nor sepsis. 80% of patients who achieve ROSC code again, enter hospice care, or change code status to DNR. So our future work will be to extend data collection to additional hospitals to evaluate codes run by residents compared to other providers. And the key points takeaway is, regarding discussion of code status in the outpatient setting, I think that's where this data is applicable, as well as in the inpatient setting when we're discussing code status as well. And it also guides the duration of resuscitative efforts. I'd like to thank Dr. Charlotte Balch, Tian Zhao, and Dr. Ann Impens for their assistance with statistic calculations, and also Amanda Hodnalik for assistance with collecting the list of chart encounters. These are our references, and thank you so much for your time.
And we thank you both so much for your presentation. So at this time, I'd like to open up the floor to Dr. Green and Dr. Manning. If they'd like to pose any questions, they can unmute or put them in the chat, whichever you prefer. Dr. Manning.
Hi, this is Dr. Manning, and what an interesting study. And I really appreciate that you did it in your community hospital setting. What inspired you to do this study?
So I can actually lead this one because I think I initially started all the paperwork. The short version is after coding a patient 4 or 5 times in the ICU over and over again, as a brand new intern, I looked over to my 3rd-year senior resident and she said, okay, we'll code him again for 20 minutes like always. And I said, why? And she said, I don't know, because that's what we've always done. So I asked the ICU charge nurse and she said, I don't know, because that's what we've always done. And I said, is there any benefit to 20 minutes? And she said, I don't know, that's what we've always done. So a little bit more looking into research and actually chatting with AHA to see if they had any specific recommendations was not exactly terribly fruitful. And so the project began with, when should we stop this? So that's kind of what kicked off all of this. And then as I mentioned this to various other specialists, they said, ooh, if you're looking into all these things, can you look into this too? Can we see if IV drug abuse affects this? Can we see if patient sex affects this, and so forth?
And did you, so that's really helpful to know. And I love the fact that you got curious about it. So what's your answer? Is 20 minutes the right amount of time?
I would say yes. I'd say 20 minutes is the magic number because it successfully captures the vast majority. I think 90% was my most recent math of the patients who are going to achieve ROSC. They will at the 20-minute mark. Beyond that, the odds of them successfully resuscitating just exponentially drops off. There was an unfortunate limitation from the way that our EMR system works. I wanted to also track if a patient coded multiple times and if they've had codes over 20 minutes and if that had any influence. But unfortunately, the way that our medical record system works, I couldn't track individual patient arrests.
Good, thank you. And tell us about your choice of analysis. You chose the 2-sample t-test for one of your assessments and not a paired t-test. Can you explain why you chose that?
It was recommended based on the data that I had available from the statistical team. I personally, I have some statistical background from my analytical chemistry days, but they said that I didn't have an adequate body of data based on the information that I had to do a paired t-test, I believe.
Okay, and just one more question.
Sure.
Did you look at the post-ROSC therapy? Like, was there a difference after ROSC was achieved in terms of therapy? Like, was there a difference in IV fluids or things like that? Or was that beyond your research view?
Unfortunately, that was beyond the scope of the practice, as we didn't originally specify within the IRB itself about evaluating post-ROSC efforts beyond just what was the ultimate discharge outcome. But that is actually a good question. So I will put this into the possible, maybe we could look into it further things and tell the future residents who are going to work on this project about that. But that's a good idea.
Thank you. Nicely done.
Excellent. Dr. Green, got any questions?
Yeah, I agree. I think this is really important data to add to end of life literature, code survival, code duration, how to humanely practice end of life care. I think that's really important. My main question, I guess, Dr. Manning asked a few, was what else after doing this study have you done to change your practice? It seems like it's reaffirmed your practice of at least a 20-minute code, but I'm wondering if there's any other insights that have kind of steamrolled into your group.
The big one that I can now say for certain, both in my own practice, as I am going to be a hospitalist myself, but also I've been sharing this with all of the other faculty and residents, is the emphasis that a partial code is not an effective code, and that I've actually told patients directly now, if we're putting you as partial code, we might as well push you as DNR at this point because they are not effective. And I understand respecting patient wishes, but from a medical standpoint, they do not work, they are not effective. And so I've been pushing very strongly to recommend patients, either we do everything or we do nothing at this point. And as a consequence, we've actually had less patients in the hospital with those partial code statuses so far. So that's one of the major ones that I've had.
Awesome, thank you.
And I thank you both as well. That's going to roll us right into our 11:40 presentation. And just a quick scheduling note, I did confirm with Dr. Sarmento, who was scheduled for 12:20, that she can go at noon since we had an opening there. We have, so Dr. Manning and Dr. Green, that will affect you. So we'll just roll right through 11:40 into noon, and then we'll have a little break in between. So with that being said, Dr. Nocito can stop sharing your screen, and I'm going to welcome Dr. Oman Sadiq, if you can share your screen using that green button. Here it comes. Okay, so while that's happening, this is Dr. Oman Sadiq from the Mount Sinai Jackson Park Hospital Family Medicine Residency Program, who is going to be presenting his completed project. For this presentation, Dr. Manning will stay on, and we'll welcome Dr. Elizabeth Corday as our other reviewer. So if everyone is good to go, Dr. Sadiq, let's make sure we can hear you.
Hi, good morning, everyone. Can you hear me?
Yes, you sound great. I see your slides. So if you are ready to go, the clock will begin when you do, and we wish you good luck.
Thank you. Good morning, everyone. Again, my name is Oman Sadiq. I'm a PGY3 here at Mount Sinai and Jackson Park Hospital Family Medicine Program. Today, I'll be talking to you about a retrospective analysis that we did titled Exploring Lung Cancer Screenings in Chicago's Southside Community. Some abbreviations that I'll be using in my presentation. JPH obviously stands for Jackson Park Hospital, LCS, lung cancer screenings, USPSTF, as you all know, United States Preventative Services Task Force, LDCT, which is the low dose CT, FDCT, which will be our full dose CT, and CXR, which is our chest X-ray. A little bit of background on lung cancer. Lung cancer is a significant public health concern with a high mortality rate, with high mortality rate of 125,000 nationwide, and having new cases of about 234,000 nationwide. In Illinois alone, there's a reported 9,429 new cases of lung cancer every year. In comparison to the rest of the states, Illinois had a higher rate of new cases per 100,000 at 59.7 compared to the national average of 54.6 new cases. The incidence of lung cancer nationwide is higher in men than women, as also true for Illinois. The higher mortality rate of lung cancer surpasses that of prostate, colon, and breast cancers combined. Areas that have higher rates of poverty and limited access to healthcare tend to have higher rates of lung cancer incidence and mortality. And disparities exist concerning prevalence, socioeconomic status, educational background, poverty level, and access to healthcare regarding lung cancer diagnosis and mortality rates. The current guidelines from USPSTF, which were updated last year in 2023, they now recommend screening low dose CT for high-risk individuals. The eligibility criteria is now at age 50 to 80 years of age with a 20-pack year smoking history, and either patient is still smoking or quit within the last 15 years. The reason why we use a low dose CT versus a full dose or chest X-ray is going to be first the radiation exposure. Compared to a full dose CT, you get around 50 times less radiation with a low dose CT, and also the sensitivity rates is quite a bit higher. For chest X-ray, our sensitivity rate for detecting lung cancer is around 78%, depending on which study you look at, versus around 90% with the low dose CT. Some significance behind low dose CT. Annual screenings with the low dose is going to detect lung cancer early, improving survival rates in regards to sensitivity rates as well as specificity. Data indicates that uptake of lung cancer screening is low nationwide. A study recently done using 10 states found that only 14.4% of persons that were eligible for lung cancer screening had actually been screened in the past 12 months. Timely interventions are going to reduce healthcare costs, optimize resource utilization, and improve quality of life in these patients, and also is going to target high-risk individuals, which is going to maximize benefit and minimize harms. The research question that we formulated was, what factors influence the compliance of lung cancer screening in the Southside community of Jackson Park Hospital? primary goals of this study was going to be the identify how factors such as gender and education level relate to the likelihood of individuals complying with recommended guidelines for lung cancer screening, and are higher education levels associated with higher compliance rates. Is there a gender disparity in compliance rates, with one gender demonstrating higher adherence than the other, and to identify strategies to enhance patient engagement and improve effectiveness of screening. Some secondary goals we want to look at is to investigate the diagnosis rates and determine if there's a correlation between the diagnosis and screening adherence, specifically looking at gender differences. And then is there a relationship between the diagnosis rates and compliance rates? And of course, is there a gender disparity in those rates as well? Also, we wanted to look at assessing physician compliance rates with the guidelines that were given from USPSTF. Are physicians offering lung cancer screening in accordance with the recommended protocols, or are they not? So the methods and study design, a little bit of information here. So total population size that we used in our study was 114 patients that were eligible for the low dose CT screening. The time frame that we used was 20 months duration from August of 2022 till March of 2024. The inclusion criteria was male and female patients between the ages of 50 and 80 that met the current guidelines, which is the PAC year smoking history. And the screen tests were performed by the radiologists using the lung-RAD system for lung nodule categorization. With the information that was obtained is from the EMR system with Jackson Park Hospital mainly, and also affiliated clinics like our Heme-Onc clinic, which is a few streets down from us. The abstracted data included the gender, age, smoking history, educational background, initial screening, whether they got repeat screening, and the lung cancer diagnosis based on the lung-RAD score. For the statistics, descriptive statistics was obtained using Microsoft Excel with nominal data. Chi-square analysis was conducted using MedCalc software. So some characteristics of the community that's in the study here. The total population of our Southside community is around 224,000 people, 96% of which are mainly Black or African-American racial group. And Jackson Park Hospital itself is a 256-bed community hospital, which is affiliated with various clinics, some of these which we used in our study to obtain data. Most of our patients are covered by Medicaid or Medicare. So here's some more data regarding the characteristics of the participation in regards to gender. So we have a total population of males that were in the study, 73 that met the criteria, and 41 females that met the criteria. Of the males that met the criteria, 54 of those received a lung cancer screening, the initial one. And of the 41 females that met criteria, 37 of those received the first dose, low dose CT. Of the 54 males that received their first dose, 5 of them came for a repeat dose, and 8 of those canceled their repeat dose, and 11 male patients that met criteria but did not receive a screening was 11. Of the female population of our 41 that met, of course, 37 received the first, 11 received their second dose, 1 patient canceled, and 3 female patients met criteria but did not receive a screening at all. So some attendance of initial screenings and follow-up visits. This is basically just showing you that 91 participants attended their initial screenings, male and female, between the 20-month duration that we were looking at from August to March of 2024. 16 total participants attended their annual repeat screenings. 9 total participants canceled the initial screenings and did not have subsequent visits. So here's a graph showing you some initial screening rates in accordance to gender. The initial screening rate amongst men was 74%, and amongst women it was 90.2%. And the analysis of initial screening rates between genders revealed a statistically significant association with the p-value of 0.04, showing that a higher proportion of women met the eligibility criteria and also underwent initial screenings. Here is a chart showing the repeat screenings and compliance rates. The repeat screening rates were used to assess the compliance rates. The compliance rates in women were 29.7%, and for men was only 9.2%, with a p-value of 0.01. So after we found this out, we wanted to see why the males had such a low compliance rates in comparison to the females. So we looked at cancellation rates and also education background. So the cancellation rates for the males, males received a cancellation rate of 12.9%, while females had a significantly lower cancellation rate of only 2.63%. And the higher cancellation rates in males may indicate barriers that impact adherence to screening participation and other factors. So looking more at the males in particular as to why their compliance rate was so much lower than our female participants, the male patients received either, on the left here, you see 9.38% of male patients that were high school educated had a compliance rate of 9.38% versus 9.09% were educated only up to the elementary level. The statistically significant association here is with the p-value of 0.04. Showed that there's an association here between education levels and compliance rates for lung cancer screening. So here we have a chart showing you comparison of lung cancer detection and compliance rates. Lung cancer was observed more frequently in men than in women, with the lung cancer detection rate of 37% in men versus 32.4% in women, respectively. Analysis of compliance rates with repeat screenings and lung cancer detection revealed what's an extremely statistically significant association with a p-value of less than 0.01, indicating that participants who complied with repeat screenings were more likely to have lung cancer detected. So here we have a chart showing about the lung cancer screening detection by education level. On the left here, you can see that detection level was significantly higher in patients that were only educated up to the elementary level and significantly lower in those that were educated up to the high school level, 23%. And on the right here, we have the lung cancer diagnosis by gender, which the males was vastly superior in terms of also participation and also national average as well. 20 of those patients had a lung cancer diagnosis and 12 of the females had lung cancer diagnosis. With the p-value here being 0.04, which suggests a statistically significant relationship between educational backgrounds and lung cancer diagnosis. Also, we were looking at physician compliance rates. Here we have a chart showing you 15% for the males, which means that 15% of these male patients did not receive their screening as recommended by the protocol, and 77% of females did not receive. So this shows you that the males were also not being screened properly. So a little bit of discussion here. The average age of women for initial screenings is around 64, and for men it's going to be around 65, slightly higher, which exceeds the recommended age range a little bit by the USPSTF guidelines. This suggests a potential delay in screening initiation among some individuals, leading to missed opportunities for early detection. Gender disparities are also prevalent in the rates that we observed, around 9.2% in men and 29.7% in women. The p-value here was 0.01, which is statistically significant between gender and repeat screenings. This aligns with the previous studies demonstrating lower adherence trends amongst men in Black communities, which was done in 2022. Amongst these men, compliance rates were lower in elementary educated versus high school educated men. And this finding suggests that educational background may play a role in influencing compliance with lung cancer screening amongst male patients in our study. So also lung cancer was more prevalent in men versus women, with 37% in men and 32.4% in women, supporting prior studies revealed by in 2023, showing that men are more likely to have a higher risk of developing lung cancer compared to women. And lung cancer detection rates revealed that elementary educated patients versus high school educated patients had a higher level of lung cancer detection rate, which also aligns with previous studies that were done in 2018. And the physician compliance rates revealed more men did not receive their lung cancer screening as compared to women, which may contribute to higher lung cancer detection rate in men within our study population. And further things that we can do is give educational interventions such as visual aids to enhance awareness and promote regular screening. Participation is warranted in these kind of communities. So in conclusion, the most highest statistically significant relationship revealed with the p-value of 0.01 revealed that there was a significant relationship between compliance and lung cancer screening and also with lung cancer detection. And here are some challenges that we faced. The accuracy of the data comprehension and patient records is compromised due to the division of different EMR platforms that we used and paper-based records that were used in other clinics. Compliance rates might not be accurate because not all patients have annual follow-up as of 2024. Small sample sizes are going to limit the generalizability of these results. The difference in participant rates as well. We had more men in our study than females. Inaccuracies in self-reported smoking history can also lead to misclassification of patients' eligibility, whether or not they can even get the lung cancer screening. And also patients may underreport or overreport their smoking history. And also physicians incorrectly classifying patients, which would impact these compliance rates. I want to give a special thank you to Dr. Keswani, who was my attending researcher supervisor, and also Sophia Tahir, who is a medical student who helped me with the statistical analysis. Thank you.
And our thanks to you, Dr. Sadiq. At this time, it's Dr. Corday and Dr. Manning. If you have any questions, you can unmute or put them in the chat. Only our assigned reviewers can ask questions of our presenters.
Hi, this is Dr. Corday. Thank you for your presentation. It was really insightful. I was wondering, when you talk about adherence, you had a good number go for their initial screening, but then follow-up to annual screening dropped off significantly. Were you able to do any sort of chart review or documentation to understand education that may have been given to patients for their understanding that this is an annual test versus perhaps a once and done? Do you know what kind of education was received or how you could potentially improve that?
Yeah, thank you for your question. So basically, the population that we're studying, typically when you try to explain to them that this is an annual test, they'll come back to you and say that they already had this test. They don't really understand the importance of getting it every year. They're under this preconceived notion that one-time test is good enough for them because most other tests that we do has a greater length. For example, like colonoscopy screenings, they only coming in every 5 or 10 years. So patients have this preconceived notion in the back of their head that why should I, come back for this test every year? Which is why I think it's very important to educate this population using a lot of visual aids and maybe pamphlets or charts and diagrams, or maybe even a visual representation as to why it's important to come every year. And most patients that I've seen in the clinic, and they've only really had one screening in their chart, and they don't really want to go for a repeat screening.
Yeah, I think it'd be interesting to you or your colleagues in your program to investigate further, because I think, there's a lot of education, for example, around mammography, and everybody kind of knows that mammography is once a year. And if there would be a way to educate the population that in a similar fashion, lung cancer screening, if you meet criteria, is once a
year. Yeah, exactly. I think that would be great for them.
Thank you for your study. What inspired you to take this study on? And the second question is, how was your population selected? Because I know you said you had 224,000 people in the Southlands community, but I wasn't sure that you were looking at that whole population.
Yeah, thanks for the question. So what initially sparked my interest here was one, when my research advisor, Dr. Keswani, he kind of led me towards this topic, but also because in our clinic, we see a lot of patients with vast great numbers of smoking history, who have smoking for many, many years. They also change their story up every time you ask them. So that's kind of a really big discrepancy whether or not they meet the criteria or not. And also patients that did have the lung cancer screening, I never really seen them come in for multiple screenings. When you look at their chart, they really just have one in their history. So that kind of led us to investigate a little bit more as to what's going on here.
And how was your population selected? That were you? I didn't get that. Was it you looked at everybody who had a low dose CT scan, or you looked at age groups? How did you select them?
So yeah, good question here. So the total population that I was looking at was 224,000, which is the entire Southside community. But the study itself was looking at patients that were in and around Jackson Park Hospital and surrounding clinics. So I used 114 total patients. Of those that met the criteria, 114 patients met criteria for screening, and of those, this is the numbers here. So 73 were males that met criteria, meaning that they were between the ages of 50 and 80, and also had a 30-pack year smoking history, and also either had been still smoking or quit within the last 15 years from the
Okay.
USPSTF guidelines. Yeah.
Thank you. And did you look at the education gender connection for women? I know they had a high rate of compliance.
Yeah, so that's a good question. We were going to look at that, but because of the low number of actual women that had the screenings in our study, it was a rather statistically insignificant graph that we came up with. So we didn't really include that, and also because the main reason why we even wanted to look at that was because of the difference in compliance rate. So we have the low compliance rate here when the men compared to the women. So we wanted to see why it was so low in the male population, which is why we kind of focused just on the male population here in regards to education background.
And can you tell me about your choice of your chi-square to look for relationships? How'd you decide on that?
Yeah, so we used the chi-square analysis because of the nature of the data. So we had mostly categorical variables, and we used a two-tailed chi-square analysis.
Okay, and final question is, how will this change your practice? I think that relates to Dr. Corday's question.
Yeah, definitely. I think I would definitely take a lot more time explaining to patients that, this is a yearly test. This is not just a once in a lifetime test that we do. We want to do this in accordance, almost similar to the mammogram screening that we have. And I think handing out pamphlets or having charts, posted in patients in the clinic rooms, I think would be very helpful. And also just education to this population, because, it's not like they don't want to do it because they don't want to do it. I think it's just a difference in understanding.
Thank you.
Great. Thank you so much. And just so you know, I want to keep us on time, but if you don't mind, Dr. Sadik, there was a question for you in the chat from Dr. Gupta. So if you don't mind going into the chat and replying to that question, if you're willing to, that's just kind of a bonus. But I didn't want to leave that question unanswered. And you can stop sharing your screen. And we'll go ahead and ask Dr. Sarmento to get ready to share her screen and unmute and make sure that we can hear her. Let's see, Dr. Sarmento, can you unmute and we'll make sure we can hear you? Let's see. And while that is happening, Dr. Sarmento can unmute and share her screen so we can see her slides. Oh, she said she's having a hard time unmuting.
Oh, can you guys hear me?
Hi, hello. Okay,
Thank
while you're
you.
sharing your screen, I will introduce Dr. Carolina Sarmento from the Hinsdale Family Medicine Residency Program, who's going to present her completed project. And as a reminder, Drs. Manning and Green, I'm going to need you again for this one. As a reminder, you'll get a 2-minute warning in the chat when you hit that point. And then our reviewers, Dr. Manning and Dr. Green, will have some questions for you when you finish. We can see your slides. We know we can hear you. So the clock will begin. You'll have your 15 minutes, and we wish you luck.
You. So as she said, my name is Carolina Sarmento. I am one of the third-year residents at Hinsdale Hospital and at Hinsdale Family Medicine. So my project was called Hypertensive Disorders of Pregnancy and the Social Environment, which additional risk factors emerge in a low socioeconomic status population. So I have no actual or potential conflicts of interest in relation to this program or presentation, and I have no financial interests or relationships to disclose. So just a small background, low socioeconomic status has emerged in our literature as a risk factor for the development of preeclampsia. In 2018, the guidelines for prophylactic use of aspirin in the prevention of preeclampsia, according to ACOG, includes low socioeconomic status as a moderate risk factor. Different organizations and different literatures define socioeconomic status in different ways. From what I have reviewed, the basics really have come down to educational level, income, occupation, which included a manual versus non-manual occupation, eligibility for government aid, inadequate prenatal care, iron deficiency or poor nutrition, stress in any living environment, which included housing insecurity, the frequency of unhealthy behaviors. So this tended to be more of substance abuse, and then unintended pregnancy, neighborhood hazards, noise pollution, and local crime rates, as well as transfer of care providers and mental illness. So there is contradictory results according to race and ethnicity in regarding to the preeclampsia risk factors and socioeconomic status. So some studies, such as one in Massachusetts, showed a comparison of gestational hypertension between Hispanic women and non-Hispanic white women. No significant difference in the number of prenatal visits, public aid, marital status, years of education between those who developed gestational hypertension and those who didn't. There are other studies that also found that preeclampsia remains elevated in Black women of higher socioeconomic status and chronic stress. So based off of this information, I looked into different numbers and different risk factors. So I calculated, so there was history of hypertensive disorders in pregnancy, multiple births, BMI, Black race, age, any autoimmune. For poor nutrition, I really looked at the hemoglobin at entry to prenatal care. Inadequate prenatal care, so I looked at the gestational age of entry, as well as the number of prenatal visits, as well as the transition to different prenatal doctors. Unhealthy lifestyle, this was included in substance abuse, either drug abuse or alcohol abuse. Life stressors, if there was any pre-existing medical or psych illnesses. And then distance as well from the patient's house to the hospital. So each patient had their address listed, so I was able to calculate that in miles, as well as number of medical transitions and then social problems. Usually I looked into housing insecurity and domestic violence, as well as economic stressors. So each patient, I calculated their poverty rate as well as their crime index based off of their zip code of where they were living at the time of their prenatal care. So my objective was to compare the presence of social risk factors between low-income patients with hypertensive disorders of pregnancy and low-income patients who do not have hypertensive disorders of pregnancy. And then I wanted to see if there was an actual association between the social risk factors in development of hypertensive disorders of pregnancy between racial and ethnic groups. So this was a retrospective chart review. I had a record of all the patients that gave birth at Advent Health Hinsdale from 2020 to 2023. So this was specifically collected during COVID. I had their physical records and labor delivery, and then I further extracted information from Cerner, which was our database at the time. Their insurance status was determined. I looked if patients were self-pay or Medicaid, and then I selected them for further investigation. Their inpatient medical records and prenatal records are then examined, and then I plotted them in the chart. And their patient information is linked to their patient MRNs and stored in a Advent Health protected, password protected laptop. So my inclusion and exclusion criteria, I included the patients that delivered infants at our hospital from this time period if they were Medicaid, insurance, or self-paid. I excluded any private health insurance coverage or patients who were already on aspirin prophylaxis for preeclampsia prophylaxis. So I collected about 121 patients that were included in this study. I was able to divide each of those variables, and I collected different data and went over them with a statistician in different forms. So one of the forms that we used was a crosstab. This was used to compare our yes or no variables and seeing if there's any difference between those with and without hypertensive disorders. So with all of the data collected, the cases are actually very low. So the statistics did not work for us to do it. So you could see that substance abuse with hypertensive disorder, there was only one patient out of the 121. Same with marital status, abuse, housing. And then race was divided into the different race groups that were listed in the EMR. So American Indian or Alaskan, Asian, Black, other, or unknown, and white. We did a t-test to compare the means for the two groups for the variable where an average could actually be calculated for. So it showed that BMI had a significant difference that we can see here, as well as the number of medical transition was also significant. And then finally, I had a correlation with the hypertension status that was significant for BMI. So I had a low correlation number. You can see it's 0.219. But it is statistically significant that BMI does contribute to hypertensive disorders. So in conclusion, my primary objective was to compare the presence of social risk factors between low-income patients with hypertensive disorders of pregnancy and low-income patients who did not develop these disorders. The largest social risk factors in these who developed hypertensive disorders of pregnancy was BMI, as well as an increase in transition to medical care. My secondary objective was to determine whether the association between social risk factors and development of hypertensive disorders varied between racial ethnic groups. And it was shown in my study that racial and ethnic groups were not deemed to be an association between these social risk factors in the development of hypertensive disorders. These are the references that I was able to use. That's it. Thank you.
And we thank you as well, Dr. Sarmento, Dr. Manning, and Dr. Green. If you have any questions for, please unmute or throw them in the chat.
Hi, thank you. So Dr. Green here, I'm taking this all in and thinking you did not find that race and ethnicity had an increased association or predictive of hypertensive disorders of pregnancy. And I think that is an important thing to know, that that's not a great marker of the risk. And unfortunately, it's one that's used, pretty quote unquote conveniently or easily all the time. And so I think that's just important kind of data to show that we should maybe not be using that, and instead looking at the social drivers, like you've mentioned. I guess in terms of seeing that information, what do you recommend in terms of deciding whether or not someone meets criteria for aspirin, or what do you feel like your study has added to our decision-making process in the future?
Yes, sir. That's a great question. I think that race makes it very difficult. Like you said, it didn't show any statistics or any evidence based off of our population in Hinsdale. So what I did see most often was the number of transitions in medical care. So patients who never had a specific doctor or who went through multiple providers. I found that this could have caused additional issues. Maybe it was because of their housing. Maybe it was because of affordability, and it was just difficult to get to the physician. So that did show some increase in that. So I do think that it is important that's not typically a question that I ask my patients, is how many physicians have you seen before you come to me? But that would
Right.
be something important to consider, as well as I did see, as we already mentioned, the risk in the BMI, and it was correlated with how high their BMI was. So those with the BMI just slightly obese was very different than the BMIs that were in the morbidly obese category. So I
Okay.
think that's more important too.
And with transitions of care, I guess at first I took that to mean like even just in like prenatal care, so start in one location, switch to another, but you're even sort of insinuating maybe just like not having a stable medical home, right? And so someone who had like, you know, their adult preventative care or sick care in one location and then now come to a totally different location for prenatal care, that's what you're referring to?
Yes, sir. And some patients who also did multiple different prenatal care providers within their single pregnancy. So the greater number of those different prenatal care centers, I would say, also increased their risk of preeclampsia. Or in this study.
Okay, thank you.
Thank you.
Hi, Dr. Manning here. Very interesting study, and here's the set question. What made you curious about this to explore this issue?
That is a great question. So I am a Hispanic female, and this was a topic that I really wanted to evaluate based off of the race perspective. It was something that I always see listed. I even have the chart pulled up with me, and you see race as a topic of moderate risk factor for having preeclampsia and to starting aspirin prophylaxis. So I just wanted to see, is this actually true? Is there enough data? And from what I researched, I couldn't find the data. So I was having a really hard time recommending aspirin to my patients for just certain small criteria. So I was just really curious to see why that was and if there was any true correlation that I could see.
Great. Tell me, though, what you mean, how you define substance use in your patient population.
That is a great question. So we do, at our hospital, we work a lot with, we have some of our attendings that are addiction specialists. So we do a lot of substance abuse training. So I would say our questions are maybe more broad. So we focus on any substance abuse from medications that are prescribed. So I had questions about that. Alcohol use during pregnancy, tobacco use during pregnancy. I had pre-pregnancy questions as well as during pregnancy. But I was only seeing during that first initial visit what they were currently taking, as well as cannabis use. And there was nobody that revealed any further drug use. So those were really my main topics.
Great, thank you. And why did you exclude those who were on low dose aspirin? I was curious as to why you didn't include them and maybe analyze them as a subgroup.
That would have been, I don't think I had too much time, but I really wanted to see if the patients who developed preeclampsia and these hypertensive disorders, and I was afraid that with the aspirin use, I wouldn't have a clear patient population, that I would be skewed in my data in some way. So I did not look at that patient population. It's a good question.
And final one, I think, is that analysis question. Why did you choose the t-test? And supplementing that, you mentioned that in one slide, if you can go to that there was a low correlation but statistically significant. What did that mean?
Yes. Here, let me go back. I'm going to try to go back. So I use a t-test because I was really comparing these two variables. It was either a yes or no question. So did they have this hypertensive disorder or did they not? So with these two variables, I was able to use the t-test. But then for this one, the correlation coefficients. So as the correlation is 0.219, so it's a very low correlation, but it is less than the value that we were it is, from what I talked to the statistician, she said that it was statistically significant. But she noticed that this was the only statistically significant point in this correlation coefficient.
And what does that mean, statistically significant? I can't read the numbers very well. What was the actual p-value that you were looking at?
That is a great question that I do not have the answer to.
Okay. All right.
I'm sorry.
Thank you. Looks like there's another question
Oh,
in the
yes,
chat.
Dr. Green.
Sorry,
Dr.
yeah, I circled back with our last minute, hopefully. And
Yeah,
it's
go
more of like
ahead.
a comment than a question, but I'm curious, our health system and many health systems are doing much better at collecting like SDOH type data about housing security, substance use disorders, financial insecurity, things like that, over the last few years. I'm wondering if your health and system has done the same, and if so, further data collection I think would be very important to identify, accurately risk stratify people for risk of hypertensive disorders of pregnancy, and help us eliminate the inappropriate use of race in that setting.
That's a great point. So when I collected this data, we are actually under Cerner, and now we're under Epic. And I've noticed a huge change in our Epic system in collecting that information. I don't think we were as accurate based off of the information that we used to ask. It was usually obtained by our nursing staff, and it was not as detailed or anywhere close to where it is now. So I think there was actually be a huge change in the data collected coming forward with Epic instead of with Cerner.
I imagine you could get some real power with the across the city data. Everyone's on Epic, and so the data could be kind of uniform and similar. So that would be a really important future project.
Yes, thank you.
Excellent point about the change in electronic health records over time. It makes a difference. Well, on that note, I'd like to thank everyone who presented for us thus far. We actually are in the same block, but have a little blip in the schedule. So everyone can take a breath, multitask, refill their coffee, grab some lunch. Our next presentation will be at 1 p.m. with Dr. Carter, and I will need Dr. Corday and Dr. Green back on duty to answer questions or to ask questions and review. My thanks to Dr. Manning, who has always been a big help for this event over the years. Everyone enjoy a little break in the action, and we'll see those of you back here at 1 o'clock. Enjoy. Go. All right, welcome back to the final presentation of this block. Just a reminder for our newest presenter on board that attendees will be muted. Only the assigned reviewers, the TV doctors, can pose questions to you. They will either unmute or submit their questions. You will share your own screen, and once we see that, you will have 15 minutes. The clock will begin when you start speaking, and I'll give you a quick 2-minute warning in the chat box just so you know when you're coming to your time. And when you hit the 15-minute mark, I'll ask you to conclude. So with that being said, you can go ahead and share your screen, Dr. Carter. Your reviewers for this are Dr. Mark Green and Dr. Elizabeth Corday. Usually takes a minute for the slides to pop, and they are on their way. Okay, I can see them and we can hear you. So once you begin speaking, the clock will begin, and we wish you good luck.
Perfect. So, yeah, so I'm Dr. Carter. I'm here with one of my co-residents, Dr. Gorty. We did our project taking a look at the effects of the use of dexmedetomidine that will henceforth be referred to as its trade name Precedex on the length of stay for patients going through alcohol withdrawal requiring ICU level care. So for our disclosures, we have nothing. We have no financial interest. This is purely an educational endeavor on our part.
So our presentation is based on Precedex, which is an alpha-2 androgenetic agonist that's been traditionally used for sedation for patients like that are severely agitated, intubated patients needing sedation, and part of anesthesia for surgical procedures at times as well. But it's recently gained traction as treatment for patients with severe alcohol withdrawal. But the evidence supporting this versus classical benzodiazepines is limited and has conflicting results.
So for our review of literature, really, it was kind of surprising with how sparse the overall data is for this subject, despite how popular it was, at our hospital ICU, which was really what kind of spurred on this research project, is we just weren't sure where exactly this recommendation was coming from, as we didn't see it in a lot of the other society guidelines. So really, it seems like it stems from two main articles. So there's an article that was published in 2016 that had about 79 patients that looked for patients, again, in the similar population that were requiring ICU level care for alcohol withdrawal. They did find that dexmedetomidine, Precedex, did lead to a statistically insignificant increase in the length of overall hospital stay. In this study, though, the authors did note, however, the group that received the traditional benzodiazepine regimen ended up needing a lot more other sedating agents, ranging from just higher levels of benzodiazepine to something like phenobarb. So they did acknowledge that there may be some limitations as far as their hospitals or clinics regimen for managing these patients. Yarovich here, also in the Annals of Intensive Care in 2017, looked at a cohort of 438 patients that were again admitted to the ICU for alcohol withdrawal from 2012 to 2017. They actually did a pretty in-depth analysis of all these different variables, and their findings were kind of surprising. So on one hand, they said, hey, Precedex is absolutely great. However, they also did mention that it led to an increase of about 42.9 hours overall length of hospital stay for these patients. So while it may have done well for symptomatic management or kind of day-to-day management, it may not actually be what's best for either hospital resources or for patients' own resources.
So our objective, knowing all of these things and also knowing that it's a very popular thing used in our ICU for alcohol withdrawal patients, was to compare the effects of using Precedex plus the benzodiazepine protocols versus just the benzo protocols alone, to see whether it affected the length of ICU stay and compare that to the overall length of stay in the hospital as well.
For our inclusion criteria, we started out with patients aged 18 to 80. We looked at a data set that went from August 2017 to November 22nd. I was admitted either here at Advent Health Hinsdale or over at Advent Health LaGrange Hospital, one of our sister hospitals that does also have the same ICU attendings, rotate both here and there. We looked for patients who had an ICU admission sometime during their hospitalization. They had to have a diagnosis of active alcohol withdrawal, documented CWA scores, and they had to be started on either dexmedetomidine plus benzos or benzodiazepines alone within 12 hours of being admitted to the ICU. For exclusion criteria, we look for really two big things. So the first one is any patient who is receiving dexmedetomidine for any other reason than alcohol withdrawal. And two was developing any other significant medical problems while they were in the ICU that could not be attributed to their alcohol use, withdrawal, or sequela from dexmedetomidine. We also looked for patients whose ICU stay really couldn't be attributed to, something else. So whether that was, they were truly there for a rip-roaring pneumonia or for sepsis, and alcohol withdrawal was kind of a minor concern or something they weren't really going through in that visit. That was one of the patients we kind of decided to exclude because we didn't want that data to confound things. So as part of our chart review, we looked and recorded the following criteria. So like I said, patient's age, we looked for the overall length of hospital stay, as well as their length of ICU admission specifically. We looked for their benzodiazepine usage and the use of dexmedetomidine. We then performed a statistical analysis to see if there was actually a significant difference between the two different groups that we outlined earlier.
So the results, basically as seen here, we had about 83 patients for the overall length of hospital stays and ICU, 83 patients that fall into the group of the Precedex plus benzo treatment, and then about 39 that fell into the benzo treatment only. The means for both overall length of hospital stay and the overall ICU stay are seen in these charts here. And then we did a t-test to determine the statistical significance between the two groups and whether there's a statistical difference that we could see basically between the two groups. So as you can see in the graphs here, which is, like a pictorial depiction of the numbers that we saw prior, you can see that the Dex plus benzo treatment group had a mean overall length of stay that was around 8.93 or close to 9. And then the benzo treatment group had 5.62 as the mean number of days. For ICU stay, if we're just isolating it to the number of days for the ICU stay, the mean for the Precedex plus benzo group was about 4.14 days. And the mean for the benzo treatment only group was 2.03 days. Now, for the overall length of hospital stay, the p-value for the statistical significance was far less than 0.05. In fact, we were getting less than 0.001. For that, and that's the same thing for the ICU stay as well. So there is definitely, we can conclude a statistical significance to both of them, which we'll go over in a little bit. So as I said here, this is just so as I said here, this is just another description for that, including the confidence intervals that do not include 0 for the difference in days between both of these groups. So the difference for the days in the overall length of stay for the Precedex and benzodiazepine groups was about 3.312 days greater for that group than the benzodiazepine group. And for the overall length of ICU stay, the Precedex plus benzodiazepine groups had a 2.119 day difference than the benzodiazepine.
So overall, it appears based off of the protocols that we use here in our hospital that we can say pretty definitively that it leads to an increased overall length of not just ICU stay, but overall length of hospital stay. Some of these things that we did notice when we were looking through the data is, there were some issues as far as when you use dexmedetomidine, basically 100% of the time, these patients ended up being intubated. So there tended to be a lot more of a prolonged ICU course just required to get patients weaned off of the ventilators, back rehabilitated, as opposed to our traditional benzodiazepine only treatment. So with our study, although we did look over a pretty big chunk of patient populations and charts, we are just 2 hospitals that are in the Chicago area, so relatively homogeneous, more Midwest focused population. We did also, work at our 2 hospitals, so we do have our hospital alcohol detox protocols. So if you are at a different hospital that did use a different protocol, that can also be a potential variable that people would have to look at. But our study does highlight that, even though the use of dexmedetomidine is so widespread, there may not actually be a particular great basis for using it other than, hey, we're really sedating our patients and kind of having it be more of a behavioral chemical restraint as opposed to a true treatment for this illness process. So these are our references for the main sources of data that we use for our review of literature here. And I think at this point, we're ready to turn it over to questions if there are any.
Great. Thank you both, Dr. Carter and Dr. Gorty. As I mentioned, our reviewers, Dr. Corday and Dr. Green, are ready with their questions.
Hi, Dr. Green here. Thank you so much. Interesting study. And I think interesting to always question the things that seem to be routine around us and ask why and if it's actually a good idea or not. I guess I'm wondering if you had any theories if the group and the Precedex group was somehow sicker, more medical comorbidities, renal issues, cardiac issues that required sedation and maybe contributed to length of stay, if that came up at all?
Yeah, so that's one of the things when we were going through the charts, we actually screened pretty heavily for, and one of our criteria was we wanted to make sure that they were almost exclusively being transferred to the ICU for alcohol withdrawal. And there wasn't some other poor underlying status that their admission could more likely be attributed to. So we really tried to focus on patients that, didn't have underlying, whether it was, like metastatic cancer or, incredibly bad heart failure and also seeing cardiology and having, cardiac procedures. and really try to isolate, so if we're focusing on the acute withdrawal picture here, what can we try to isolate and distill down so we actually get something that's focused more on like you mentioned, the actual disease process as opposed to alcohol withdrawal plus, heart failure or other conditions in the mix.
And just to add to that, we also, that wasn't just like, we weren't just using what was the primary diagnosis for admission to the hospital or the ICU. We went in deeper to that as well. So even if something developed later, that might have skewed the results for that, we also eliminated those patients from our patient population, so that we truly were looking at least as much as possible for Precedex, like isolatedly Precedex versus like benzodiazepines in patients that were really admitted for just alcohol.
If we had, I think, at least one or two patients where like they would be intubated, and they would have an aspiration pneumonia or something and end up being septic, and from an alcohol withdrawal standpoint, their COs are showing everything was well contained, but their vitals, just with their now infection, weren't letting them get downgraded. So we really combed through basically their day-to-day charts once we had somebody we were considering including in our study.
And can you remind me how many were in each group?
Yeah, so the N number for the Precedex plus benzo treatment group was 83. And for the benzo treatment only group was 39. And that goes to reflect also that, it's a common practice, kind of like a more common practice, at least within our hospital system, that we do use Precedex.
Yeah, it wasn't like we were ended up with more people we're excluding. It's that genuinely we were ending up with this 3 or 4 to 1 enrollment ratio just from standard of practice over the past couple of years.
And given that it seems like the Precedex group had worse outcomes, I'm curious, what the ethical implications or implications for practice are at your hospital system.
Yeah, and this is something we brought up with the ICU doctors. Part of the problem is right now, with the data, kind of coming from, I guess, in their eyes, the much stronger study from the Journal of, the Annals of Intensive Medicine. They're saying, well, our practice guidelines and our evidence is saying this, but if we can get some more data, we might, start changing kind of how they practice. But right now, they're still pretty heavily using the dexmedetomidine.
Interesting. Thank you so much.
Thank you. This is a really interesting presentation. Thank you so much for sharing it with us. I do have a couple of questions to sort of follow up on some of the things that Dr. Green asked. So we know that it's the intensivist group at your hospital, and you mentioned that there is a protocol in place. Can you describe the protocol a little bit? Like, what criteria are being used to decide which patient would get Precedex plus a benzo versus benzo only? For example, are they looking at total CWA score or over a certain number of hours before initiating?
Yeah, so just a point of clarification. It's not really that there's a protocol they use to decide, who gets Precedex or who doesn't. It's more the criteria that we use, kind of the more protocols we use to manage alcohol withdrawal here at our hospital. Just due to staffing, right now we use a fixed schedule plus PRN dosing based off of their CWA scores. However, the current gold standard that's put out there is a strict PRN schedule. However, that does get very hard if one, you don't have staff, because it really does take nursing quite a bit, because they have to come back, every 2 minutes and every 5, every 10, every 15 as their CWA scores allow, and continue with the benzos. So that's why we do that here. So that's why I was saying there might be a little bit of a difference between hospital if your hospital is able to accommodate the PRN kind of gold standard that is out there. But as far as our hospital group, it really, or our hospital itself, our intensivist, it's really kind of more of a behavioral kind of clinical judgment. It seems like it's more geared at the more severely withdrawn patients, or the ones who are just having, more behavioral concerns. That's what I mentioned at the beginning. It's my impression is it seems more of a chemical restraint almost than a true treatment for people with alcohol use.
So my second question then, and I think something you said, maybe I missed, or regarding like their length of stay might be increased for the fact that they're intubated and sedated, and then monitoring their CWA scores after that. Can you expound on that a little bit more? Like, how do you decide when to turn off the Precedex?
Yeah, so a lot of that is kind of, again, intensivist driven. There's not a true protocol. It's really just our standard ventilation weaning protocol. We keep their RAS scores between 1 and 2. We have protocols where, we try to get people off the vents daily. So again, it's really kind of going back into that. There's not a whole lot of guidelines that are out there, despite this being so widely used by everybody.
The generalization I think that we can see kind of with these patients is, you put them on Precedex, for either for very high CWS scores, plus and minus, like a judgment call on like their behavior and etc. And then every day they'll do a ventilator wean. And if they're breathing on their own, they will wean off the Precedex and see what it's like. If the patients are incredibly aggressive or showing high levels of hallucinations or anything like that, they will then reinitiate the Precedex. Otherwise, they will wean them off. So that's generally, the protocol kind of being used, but it's very judgment based as opposed to a strict protocol.
And it's hard when you have that, because like I said, our goal is ideally those PRN based benzodiazepines based off of their CWA score. Well, the problem then becomes, well, if they're sedated and out of it, how can you possibly do a CWA score? So it would make sense that if you're just doing your fixed taper and a patient who's severely withdrawing and has elevated CWAs, they're obviously going to need additional benzo, but you can't kind of gauge that or stay on top of their withdrawal symptoms if they're sedated. So it really kind of becomes a chicken or egg scenario in a lot of these, where it ends up being a lot of, at least in our impression, is a lot of just waiting out the withdrawal symptoms and sedating them until they're basically done, and hoping that when you try to wean them, they're over their withdrawal.
And then one last question. How does this study influence your practice in the future, and how you might care for alcohol withdrawal in the future?
Yeah, I'd say from my personal standpoint, on paper at least, I think Precedex is like any drug, it has its place in medicine. Based off of our study, do I think it necessarily should be our go-to, our first line for our alcohol withdrawal patients? And I would say largely no. So I'd say from my standpoint, I would still err on the side of with the more traditional benzodiazepine PRN scheduling. Now, if there's more data that comes out in the future that says, yes, in a hospital that has more nurses and more staff and able to keep on top of things, that Precedex is fine, I'd be open to trying it again. But I don't think it has a place right now as first line for really any alcohol withdrawal.
I agree with that statement. I think that first of all, I know that, like, for example, there are hospitals like our hospitals that don't have like an alcohol withdrawal or like drug withdrawal units with nursing staff that are familiar with like PRN regimens and identifying early on withdrawal signs, etc. So this that would be something that I think would be a beneficial thing with people just having more training on how to do those things, and then leaning on the side of the PRN treatments as Precedex as a more last resort is what I would go.
Thank you.
And thank you both for your presentation, and to both our reviewers, Dr. Green and Dr. Corday. Dr. Corday, I will see you back again at 2 o'clock for one more. That concludes this block. Just to follow up, all the scores that will be submitted from our reviewers throughout the day will be compiled and shared back with the lead presenter for each presentation by the end of day tomorrow. So we'll look forward to sharing those individual results with you, along with a link to the recording. That's it for this block. We'll be back at 2 o'clock p.m. with a jam-packed block of 6 presentations. Dr. Corday, I'll see you for the first one. Thank you, Dr. Green. Thank you to everyone who presented during this block, and to those of you who have joined on the watch. Hopefully we'll see many of you back in just a few minutes at 2 p.m.
Thanks.
Well, welcome back to the last final block of the 2024 Resident Scholarly Works Virtual Summit presented by IAFP. Just a reminder, I'm Ginny Flynn, Vice President of Communications, and happy to moderate today. Unless you are the presenting resident, please make sure that you're muted. And our presenters have the option to use their camera or not. We hope you do. We have 6 presentations in this block. And we also have a couple of anonymous reviewers on board who will observe your presentation, make scoring based on the criteria, and also ask you a couple questions after you present. Quick review of the process. Only those TV doctors can ask questions. They'll either unmute and ask you live after you conclude or put it in the chat box. You should have your first slide ready to go on your desktop. And then as you start presenting, once you get down to 2 minutes, I'll put it in the chat that you have 2 minutes remaining. And if you hit 15 minutes, I'll ask you to conclude. Other than that, I do have to do the fun thing of our CME accreditation statement, which is required. Since I did it at the top, we'll kind of do the abbreviated version, but the Illinois Academy of Family Physicians is accredited by the ACCME to provide continuing medical education for physicians. And IFP has designated this internet live activity for a maximum of 2.71 AMA PRA Category 1 credits if you were on all day. Otherwise, when you submit your evaluation, you can submit for CME credit for each presentation that you view. And for this final block, I'd like to report that Dr. Tanawan, Dr. Bray, Dr. Elgar Barwi, Dr. Asadullah, Dr. Lamb, Dr. Hashmi, and Dr. Buma disclosed no relevant financial relationship or interest with a proprietary entity with respect to producing, marketing, reselling, or distributing healthcare goods or services. So everyone has submitted their CME disclosures. We have everyone on board that we need. So with that said, I'm going to run through just a couple other announcements. This link for the CME credit, I will put in the chat once again. Just a reminder that all our presenters are invited and encouraged to submit their abstracts for Family Medicine Midwest this fall. The deadline is June 2nd. And we also have just coming up a week from Friday, our White Sox game, which benefits the foundation. All these links are right off our homepage on our website. And we've added a Chicago Sky game in August. So a great time and something that hopefully families can come out for. We are still looking for our annual awards nominations. They are open until July 1st, so plenty of time. Easy online form. Again, this is also off our homepage and easy to find. And if those of you who are still in residency or looking for a change, there are a lot of resources on our Career Center. So I want to make sure you're aware of that. With that, I'm going to stop sharing my screen and ask Dr. Tawanan, I'm sorry, I got it wrong, Dr. Bray, to go ahead and share your screen. And then once we can see your screen and see that you're ready to go.
Perfect.
And while you're doing that, our presenters are also from the University of Chicago. I'm sorry, I take that back. From the Ascension, Illinois, St. Mary Family Medicine Residency Program in Chicago, and they are presenting their research in progress. So with that, I will let you know as soon as we see your slides, and you'll be able to take it away.
Perfect.
Okay. There we go.
All right.
All right, we can see you. And with that, we wish you luck and the clock.
Yeah.
There we go.
All righty. Well, good afternoon. Thank you everyone for having us today. My name is Dr. Tanal. This is Dr. Bray. As Jenny mentioned, we're residents here at Ascension, Illinois, St. Mary's Family Medicine Residency. And part of our residency experience is instead of having our clinic experience outpatient be part of one of the Ascension affiliated clinics, we actually have a longstanding agreement to do our continuity experience with Prime Care Community Health, which is an urban FQHC of 7 clinics that serve the far west, northwest, and west sides of Chicago. So a little overview of our project and Prime Care. So like I mentioned, Prime Care is an FQHC network. We have 7 sites on Chicago's northwest and west sides. And we do offer full spectrum family medicine, prenatal care, geriatric care, well child's adult care. We run the whole gamut. Prime Care has recently introduced a weight management focused clinic twice weekly at one of our clinic sites. We do an internal referral system where any PCP at one of our 7 locations can refer a patient for comprehensive weight management. We have a family physician, a nurse providing counseling for nutrition, and also a behavioral health consultant, social worker offering behavioral health support. And going off of USPSTF guidelines for effective interventions for weight loss, inclusion in this clinic's model right now is patients committing to 12 to 26 sessions in a year, bi-weekly, so that we can have close follow-up and monitor their progress.
Then a quote that we found that kind of helped inspire our project was, "It's not just about losing the weight, it's about losing the lifestyle and mindset that got you there." So we feel that this project was important to pursue because although the clinic that we were focusing in on from the data is a weight management clinic, we found that in all of our sites, patients with trouble with weight loss and obesity has an effect on other chronic comorbidities that we manage. So we felt that this would be an important impact not only on the number on the scale, but their health in general. And then a little bit of background on obesity itself. In 2020, 41% of US adults between the ages of 20 to 44 were considered obese. This is a 33% increase from 2009 and double since 1980. And since 1980, when the epidemic emerged of obesity, multiple strategies have been implemented to treat and prevent, but with little success. So Prime Care is using evidence-based interventions and data to provide patients with a comprehensive and holistic approach to weight management.
So as we I think we briefly touched base on our pillars for our weight management clinic, but objectively, we have nutritional counseling. So the first visit is actually 45 minutes long. We have a dedicated LPN who provides nutritional counseling followed intake encounter. We calculate the patient's TDEE as well as take a body composite with an impedance scale, so we can help them create a weight loss plan and allow them to be in a moderate caloric deficit in a way that works for them. We also have a BH consultant employ motivational interviewing techniques to kind of meet the patients where they are, set goals together, and follow up accordingly. We also have this BH consultant receive counseling about the relationship with food, if there's any maladaptive coping mechanisms that are associated with food, and also helping assess what socioeconomic determinants of health may be playing into the patient's difficulty in attaining weight loss. Prime Care does serve communities that are in a particularly significant food desert and wellness desert. So our BH consultants are integral in helping us make sure that we're assessing all of their needs past metabolic intervention. And the fourth pillar of our weight management clinic is medication. So medication assistance is offered to patients who qualify, particularly those who have comorbidities like prediabetes, diabetes, hypertension. And then we also employ a variety of medications, including GLP-1 agonists, phentermine, topiramate, bupropion. And if a patient does screen positive for binge eating use disorder, we also have some data of some patients using dexamphetamine for weight loss.
So our hypothesis for this study was that implementing more frequent visits with a multidisciplinary dedicated weight management clinic will lead to sustained weight loss.
So our inclusion criteria for our study basically mirror the inclusion criteria for doing the weight management clinic. All study participants were at least 18 years old, they had a BMI of over 30, and they were all willing to commit to the program. For the purpose of the study, however, we eliminated patients who had attended less than 6 visits to our clinic.
In the design of our study, it was an analysis performed based on chart review from 99 participants engaged in the weight management clinic as described in the previous slide. And the data that we obtained from each visit included weight and BMI. And we assessed the effectiveness of the methods based on the change in BMI from intake to the most recent visit.
So here's our raw data in progress. So we were able to get 99 data points. And we arranged them from change in BMI from greatest change to, unfortunately, a few patients who ended up gaining weight within the weight management clinic. But overall, for our sample size of 99 patients, the average change in BMI after at least 6 clinic visits was around 2 points.
And throughout analysis of our data of this study, we've realized that there are some practice limitations that may have affected our outcomes. particularly for patients who were using the assistance of medications. We were able to find inconsistencies in availability of medications that are used in the weight management clinic, particularly with the GLP-1 agonists. They were previously a part of our 340B arrangement with Walgreens that was very beneficial for our Medicaid and self-pay patients to offer those medications at discounted rates. However, that for the most part has been discontinued. And these medication gaps cause delays in dosage increases for patients, as well as adherence when they were switching between agents within certain drug families.
And since we are a work in progress, so we're looking to the future about where the study will go. So given the novel nature of our weight management clinic, we really don't have data yet to reflect long-term sustained weight loss. We started having the clinic itself rolled out towards the end of 2022, but a lot of our PCPs within our FQHC weren't really aware and referring patients actively until about halfway through 2023. So, we're defining sustained weight loss here as weight loss of at least 10% of their body weight and keeping it off for at least 1 year. So we're just going to continue to follow these BMI points, weight points, and see if we can find more meaningful data in the future. We also anticipate an increase in enrollees to the clinic, given improving formulary status changes for GLP-1 agonists and increased patient interest in medication-assisted weight loss. I believe right now for Medicaid patients, for example, Trulicity is on the formulary. And then we also want to look at significant positive effects maybe in the future that significant weight changes have on other chronic metabolic conditions, such as having better control of hypertension, diabetes, as well as cardiovascular disease.
And some further goals for the future are, particularly within this study and moving the study forward, we're to compare the outcomes of weight loss over time in patients enrolled in the weight management clinic in comparison to weight loss outcomes solely based on visits with their PCP. And that we feel can be achieved once we have more data points, because our EMR that we use in our clinics, Athena, allows us to track BMI counseling and guidance as a quality measure that has to be satisfied at least once a year, if not more than that. So we hope to follow that in the future, as well as within the weight management clinic patients themselves, comparing the different resources that are used to help in this weight management. Because while we do have the 4 pillars available to most, if not all, patients, this initial study kind of grouped everybody together, but we'd like to see the comparisons between the medications themselves versus patients who solely made lifestyle modifications, but with the close follow-ups or different combinations of changes that patients made.
We just have some reference here for our presentation, but that concludes our data and what we have for you guys. So thank you so much for having us.
Thank you.
And I'd like to thank you both as well. And I forgot to mention it at the top, but we have Dr. Elizabeth Corday has returned from the last block, and we welcome Dr. Sarah Reese, who is going to pose questions based on your presentation. You can unmute and fire away.
Great presentation. This is Dr. Reese. Couple of questions. You had mentioned that I was wondering how many patients were first enrolled in the study. You said that you took out patients that were less than 6 visits. And so I wonder how many did you start out with?
That is a great question.
I think when I was going through the raw data, we had over 200 patients that were referred to the weight management clinic. But once we saw which patients had follow-up of 6 visits or more, that really pared down our data points to 99.
Were you able to identify any barriers that contributed to the attrition rate?
When we looked at to see who had the best attendance to our weight management clinic, we saw that the patients who already had a PCP at this clinic site were the ones who had the best follow-up. So our weight management clinic right now is at one of our clinics on North Avenue in Pulaski, but our clinics go as far north as Belmont Cragen and as far south as Wicker Park. So I did notice that patients who were referred out from our academic sites or from the northern sites of Belmont Cragen, it seemed that we had the most attrition from them since it was outside of their medical home.
Okay. And then my follow-up question was, were you able to stratify the data in terms of further demographics, as in like females, males, ethnicity, nationality?
We did not for this initial part of the study, no.
Okay. And sorry, last question, very interesting study. Were you able to employ any teaching kitchens or collaboratives in Chicago to perhaps help these patients learn ways to cook healthier that were, you know, with keeping in mind their sort of native culture as well as culinary styles?
That's a really good point.
Yeah.
I know that we both rotated as residents in the weight management clinic, and the nurse has resources that are culturally sensitive. Our EMR Athena does allow us to kind of collect that demographic data, and during the nutrition visit, we do ask like, oh, you know, where's your ethnic origin, where's your family from, and then we try to provide counseling that's applicable to you know, what their customs are for food.
That's great. Those are the questions I had. Thank you.
Thank
Thank
you.
you.
Hi, this is Dr. Corday. Thank you very much for your presentation. I had a couple of questions. So you mentioned that you rotated through the clinic. I was wondering resident involvement and continuity with the patients over time. So if you could tell me a little bit more about that.
Sure. So as Dr. Tenawan mentioned, the weight management clinic is based out of one of the non-academic sites, but because it's still within the FQHC system that we work with, it is available as an elective to rotate through in our second and third year. So we each, and a couple other members that are part of this study, spent a month there following with the providers that provide the weight management visits. But because the patients are referred from all 7 of the sites, then we are then also able to follow if our own patients or patients from our home clinic were participants in the weight management clinic, then we do have regular routine follow-ups with them for other conditions that they're seeing. So we're able to check in that way. But it is the same 3 providers that are providing the weight management clinic visits itself.
And then in terms of continuity of care, I think a big strength of having the internal referral system is that if the weight management doctor kind of notices something amiss in between our regularly scheduled follow-ups, it was a very quick, you know, we call them Athena texts in our EMR, where I saw a patient where I was trying to work on his obstructive sleep apnea. He ended up in the weight management clinic, and one of the attendings I was working there was able to kind of like, you know, alert me right away that his CPAP machine was broken and he needed some more a DME request. So it's been a really nice kind of additional touch point for a lot of our patients that have higher needs.
Are the visits all like one-on-one with the weight management physician, or is it like a group visit where like when they're learning about nutrition, they're learning with a cohort of people?
Right now they're individual, yeah.
Okay.
Through the hospital here, we provide resources that the diabetic educator department and endocrinology department do have monthly classes about nutrition and diabetes management in general. So we do offer the resource of informing our patients when those classes are if they'd like to attend. But in terms of the clinic itself, the visits are one-on-one.
Okay. And then I had one last question. In regards to the outcomes, because your project is still in progress, correct?
Mm-hmm.
So the outcome that you, just to make sure I was understanding your presentation, that the endpoint and the outcomes that you're trying to achieve is 10% weight loss at 1 year for the patients who are enrolled?
Yes.
Okay. And does it make a difference, or will you extrapolate if they used weight loss medications, or if they did purely lifestyle adjustment, or so will you look at the difference between?
Yes.
Yes. So that is a future goal of ours. First, we kind of wanted to collect the general data, compare, see if having the specific clinic itself was beneficial for the patients in comparison to just their PCPs. But we do hope to kind of dig into it a little bit deeper to see, okay, which medications are maybe the most effective, or which changes or combinations of therapies, whether it be lifestyle and medications or just BH and medication. So yes, we do hope to kind of dig into that a little bit deeper in the future.
So I'm sorry, so you mentioned compared to their weight loss compared to with their PCP. So you'll have a control group, like you're looking at two separate arms of like individuals who are following with just their PCP and what their weight loss is over a year versus people who specifically went into the weight management clinic.
Yes.
Yes.
Yeah.
Okay. Very
Yeah,
good.
we have a very strong data. Gosh, what is Erin? Our public health consultant. So she pulls out so much data from our charts every year to look at BMI changes, BMI counseling. So I think once this weight management clinic is out of its kind of nascent phase, we will kind of get that data to kind of compare PCP only BMI touch points versus dedicated weight management visits.
So you kind of already have a baseline.
Yes.
Yes.
Okay, very good. Thank you.
Thank you.
Thank you.
And I'd like to thank you both as well and for kicking off this block. And I know we have our next presenter standing by, so you can, if Dr. Salman Al-Garbawi can share screens, we'll go ahead and transition to our next presenter.
Thank you.
Excellent. Good to see you.
Hello, everybody. My name is Salman Al-Garbawi, family medicine resident at SIO Carbondale.
Can you share your screen for us so we can see your slides? And while you're doing that, I'll give you a proper welcome. So Dr. Al-Garbawi is going to share his completed project from SIU Carbondale, and our reviewers for this segment will be Dr. Sarah Reese again, and we welcome Dr. Addison Montgomery to be our second reviewer.
Right, thank you.
Just to review, we can see your slides now, and you will have 15 minutes to present your research. When you have 2 minutes remaining, I'll put a 2-minute warning in the chat just to help you manage your time. And then once you're finished, you'll field a couple of questions from our reviewers. So I can see your slides, and if you're ready, the clock will begin when you begin. Good luck to you.
All right, thank you. Thank you so much. So I'm going to talk about exploring the hazard of e-cigarette and short-term, about the short-term respiratory effect of e-cigarette among young adolescents. So e-cigarette mainly at work, it's type of electronic nicotine delivery system. It's work either by inhaling or by pressing a button. It has been like evolving rapidly. It started first like to help people quit smoking. So there's few generation of the e-cigarettes. The first one, it's called Sega-likes. So this one, it's not rechargeable or refillable. And the second generation, it's like the first one, but it is rechargeable. And we have the third generation. It has some modification. And the fourth generation, it's called pod mode device. It's also look like the USB flashes. So the component of e-cigarette, there is nicotine part, and there is a glycerol part and the flavoring part of it. So the prevalence in US in 2021, the prevalence was 4.5% among US adults. And they did also like, they checked they did some telephone surveillance, and the prevalence was 6.9%, and the daily use was 3.5%. And for the pattern of use, it's more common among young adults, males, and non-Hispanic white. And the concern about the e-cigarette, it's about lack of regulation, misconception about purity, and also like inhalation of unknown substance and changing risk profile. So for people who use this, there is risk of nicotine exposure. And beside that, there is also like risk of respiratory irritation. And if they have asthma, it can worsen the asthma. Also the risk of burn injury and device malfunction and exposure hazard and potential health effect. And beside this, also it can has the second-hand smoking effect. There's also a disease called e-cigarette vaping associated lung injury. As of November 5th, 2019, there has been 51 cases of e-cigarette or vaping product use associated with the lung injury. Over a span of 4 months, there was 39 deaths reported in US related to EVALI. So the specific concern, as we mentioned, is about like nicotine dependence, adverse effect related to nicotine exposure, and normalizing smoking behavior. And there's also the public health concern, secondhand exposure. And there is a graph about like increasing e-cigarette in young adults. This is in Illinois. So our study is to evaluate the short-term respiratory effect of e-cigarette among adolescents in a clinical setting in our clinic in West Frankfort Family Medicine Clinic. So it's prospective cohort study. The inclusion criteria, it's for adolescents from 13 to 18 years old who are current e-cigarette smoker, and exclusion criteria for people who has chronic respiratory condition like asthma, COPD, cystic fibrosis. And the plan for like the sample size, it's 100. So the plan to like collect the data on demographic information, smoking history, e-cigarette use pattern, is it how often they have been using, and we check the baseline respiratory function from the spirometer device. And follow up at 1 month, 3 months, and 6 months to monitor the change in respiratory function and document any respiratory symptoms. So we have two variables. It's primary, if there is any change in the respiratory function, mainly FEV1 and FVC from baseline. And the second variable, it's about frequency of respiratory symptom like cough, wheezing, or shortness of breath. So the primary objective to assess the impact of e-cigarette use on respiratory function in adolescent over 6-month period. And the secondary objective to check the prevalence and frequency of respiratory symptoms among adolescent with e-cigarette user. So the study, I think I mentioned before it's completed, but it's still in progress. We just started like 3 weeks ago. And here's the resources.
Okay, thank you, Dr. El-Gabawi. We'll change your presentation category to in progress is for terms of scoring. So for our two reviewers, make sure when you do the scoring, use the in progress research criteria and scoring system for that. So that being said, at this time, I'll ask if Dr. Reese and Dr. Montgomery, if they'd like to unmute and ask their questions of your progress to date.
Thank you.
Thanks, Ginny. This is Dr. Montgomery. Really interesting study. I'm curious to know a little bit more about your symptom assessments. Do you have kind of a specific scale that you're using to ask the respiratory symptom questions around cough, wheezing, shortness of breath?
Interesting point. It's about like if they have like cough, yeah, we're gonna sit this like cough. It has been like like at least like a day or more, and with shortness of breath also and wheezing. Yeah.
Yeah, I wonder if I don't know if it is totally applicable, but maybe something like the asthma control questionnaire might be kind of a standardized way to look at that. These patients don't have asthma, but it kind of assess some of those similar symptoms. But yeah, that sounds really good. So you said you're 3 weeks in?
Yep.
Okay. Yeah, great. So it looks like you're coming up on your first month check-in soon.
Yep. And we enrolled now like around 10 or 12 patients now.
Great. Thank you. Yeah, it'll be interesting to see what your findings are.
Thank you.
Hi, I had a question regarding, I know that you just enrolled 10 or 12 participants currently, but have you noticed any kind of predilection towards one particular generation of e-cigarettes versus another based on where you're at, as well as the participants that you have?
I noticed it's more from the newest generation, like the fourth generation, but we still have like some from like third or fourth generation.
Gotcha. And then out of curiosity, how are they getting it? The 13 and the 14-year-old, I'm thinking to myself, you know.
Yeah, I didn't check that with them, but I mean it's available online. Some people can
Oh,
order
okay.
it online, yeah.
Gotcha. Okay.
And if I can ask one more question, your one of your outcomes was measuring level of nicotine dependence. How was that being measured, or is there a scale, or yeah, how are you quantifying that?
We don't have like a skill actually right now, but yeah, we're for nicotine independence.
And then just so you know, you may want to stop sharing your screen because we can still see what your screen. So you may want to hit the stop share on that red button there. There you go. Where it's got, there you go. There we are. I didn't usually, in case sometimes they need to go back and reference some of the slides during the question and answer, but doesn't appear that you need to. So do either Dr. Reese or Dr. Montgomery have any further questions?
No, thank you.
All right. Well, thank you so much, Dr. El-Garbawi. With that, we can move to our third presenter of this block. Dr. Nasiha Asadullah, if you are able to unmute yourself and share your screen with your slides. Dr. Asadullah is joining us from the Advent Health Hinsdale Family Medicine Residency Program as well today. And she has a completed project to share. For this segment, the reviewers again will be Dr. Montgomery and Dr. Reese. So I need you both to hang on for one more together. And I appreciate both of you today. All right, so we can see your slides.
Hi guys, can you guys see them okay?
Everything looks good. Just a reminder, you'll have 15 minutes. The clock will begin when you do. And then when you get down to 2 minutes, I'll put a 2-minute warning in the chat and ask you to wrap up if you actually do hit 15 minutes. Otherwise, the floor is yours and we wish you luck.
Sounds good. Thank you so much. Hi, everyone. I'm Nasia Asadullah. I'm a resident at Hinsdale Family Medicine Clinic, or Hinsdale Family Medicine Residency, rather. We did a presentation, my co-resident, Dr. Reena Patel, and I, who's unfortunately not able to make this presentation with me today, but I am here to talk about our research that we did. There's a QI project. The title is here, pneumococcal vaccination rates in patients 65 years and older. Specifically at our clinic, which was a retrospective cohort study, and we assessed vaccination rates in comparison to the CDC statewide rate. No disclosures or conflicts of interest for this study or presentation. I wanted to just give you a little agenda here. We'll talk about background really quick, the QI project itself, objectives, data collection, analysis, conclusion and data, and discussion, and then improvements, and then finish up with the appendix. All right, the background here. So just a little bit about pneumococcal disease itself. It's an infection caused by Streptococcus pneumoniae or pneumococcus. It can lead to invasive and non-invasive diseases. So some of the invasive ones are listed above: pneumonia, bacteremia, meningitis, that all lead to sepsis, requiring ICU care and longer hospital admissions. Non-invasive pneumococcal diseases such as otitis media and sinusitis. The transmission is direct contact with respiratory secretions such as saliva and mucus. Some risk factors for pneumococcal disease. We specifically focused our study on patients ages 65 and older, but as you can see, children and adults with varying different conditions are at an increased risk of pneumococcal disease. So there's a whole other category of patients that qualify for these vaccinations early on. And you'll see children such as CSF leaks, diabetes, cancer, just any in general immunocompromised. And same goes for adults too, specifically 65 and up, alcohol, tobacco, CSF leaks like we saw in children, immunocompromised conditions, and a few others there. Epidemiology of pneumococcal disease, it accounts for, specifically pneumonia, accounts for about 10 to 25% of annually of all pneumonias. For people 65 and up with pneumococcal pneumonia, 20 to 30% actually develop the bacteremia, and then at least 20% of those with bacteremia die from it despite proper antibiotic treatment. And we, thought this was a very important disease to study because it is the most common cause, second most common cause of vaccine preventable death in the United States, in our country. Just a nice graphic here kind of shows you the cases of pneumococcal disease that increase after age 35, and then the death rate you can see that really climbs after age 50. These are the vaccine types that we have currently offered in the past and current for pneumococcal itself. And so those are the few listed. The PCV 15 and PCV 20 are the two new ones that came out within the last couple of years. A little bit about insurance coverage, because we do see a lot of patients with variety of insurances that walk through our doors. So we wanted to make sure that it was something accessible to everybody. Medicare Part B covers Prevnar 20 with 0 out of pocket. And that was since October 1st for 65 and up as well. And then Affordable Care Act made it kind of easy for commercial health plans to cover these vaccines too without a copay or anything like that when your provider's in network. And then private health insurances as of October 11, 2022, 95% of insurances do have coverage for Prevnar 20. And then just out-of-pocket costs, something we were just curious, it's $200 to $250 per shot. This is kind of where it's a nice visual of the timing for adults 65 and up. You can see here, patient with no prior vaccine. The new guidelines recommend option A or B. Option A is just a single dose of the PCV 20, and then option B is the PCV 15. And then a year after that, you can administer the PPSV 23. And then the bottom last one, if you look at, kind of shows you shared clinical decision making for those patients that have already completed the series. If they're greater than, or if they're 5 years or greater out from completing the series, they do have the option to get boosted, I guess, with another dose of the PCV20. So our QI project, we wanted to look at vaccine rates at our clinic and how they compare to the state vaccine rates for pneumococcal vaccines. We do offer the new PCV20 here at our clinic, and our goal was really to improve the vaccine health literacy and awareness among not only just our providers, but then also patients. And so the Illinois vaccine rate for pneumococcal vaccine is 70.9%. Our methodology, we specifically looked at 65 years and older patients that are meeting that criteria at our clinic, who were seen from January 2022 to January 2023, and they were evaluated for their vaccine status. We had a total compilation of 410 patients who met that criteria. Our exclusion criteria was deceased patients, nursing home patients, or inactive patients, and then we excluded a total of 50 patients. As far as data collection, we used a chart review retrospectively using our Athena EMR. And this is kind of what we had as a template through, just an Excel sheet with patient ID, name, date of birth, age, the vaccine type they received and when, and then what they were due for. We did hold a kind of like a, I guess, interventional noon conference at our residency here, just so faculty and residents could attend. And we gave them the same information, about that we had just discussed previously, so that they are aware, and to bring awareness to, I guess, our staff, faculty, and residents that what we offer at our clinic, who is able to be covered. So when patients do come in and are due for vaccines, that everyone else is able to answer those questions and have a little bit more of a better understanding of what the guidelines are, the new guidelines are, and things like that. We did also send out a few patient case reminders for patients that met certain criteria to the PCP, that the patient's PCP, that, hey, the patient's due for this vaccine, consider discussing at your next upcoming visit. So our result, before the intervention, we had about 159 patients who were fully vaccinated, and then after the intervention, so the intervention, I mean our informative discussion at noon conference, we had about 21 more patients who were vaccinated after that. Our conclusion, unfortunately, we, didn't have enough evidence to conclude a statistically significant difference in the proportion of fully vaccinated patients before and after the intervention. Our intervention did contribute to a 5% increase in pneumococcal vaccine rates at our clinic. So we kind of have a percentage of 43.9% of the 410 patients being fully vaccinated. However, even with our intervention and talk and information for everybody, our vaccine rates at our clinic is just still significantly less than the statewide vaccine rate of 70.9. Adults who were at risk for had certain risk factors that are vulnerable to invasive pneumococcal diseases, and we, talk about there's over 90 pneumococcal serotypes and pneumococcal vaccines that cover the subset of most of these common serotypes causing severe disease. Our study did look at PSV23, PCV13, and PCV20, and then we did do our intervention, like I mentioned before, where clinicians were reminded and educational handouts were provided during the conference, not only the noon conference, but then even in clinic as helpful tools towards increasing vaccine awareness. Some limitations we encountered, as far as patients go, there's vaccine hesitancy, no-shows or patients missing their appointments, whether it was a well visit or an adult physical and things like that. Follow-up appointments for completing vaccine series was a little bit challenging as well. And then DuPage insurances, we ran into this issue where it does not cover pneumococcal vaccine at annual well visits. So those, for example, if you guys aren't familiar with DuPage insurances, we have insurance as known as Access DuPage. So for those vaccines that it was not covered. Our data quality, the vaccines vaccines received outside of Illinois, so with iCare weren't included in this. And then we had our exclusion criteria for the patients. As far as data analysis goes, we did use our own statistical software, and there were, there were multiple ways to analyze the data, but there was just time was a limitation and all of that. Some future project improvements for the residents at our program who wish to kind of continue this from a different standpoint, or take a different take on it in the future. We suggested maybe evaluating pneumococcal vaccine rates from age 19 to 64 in patients with risk factors. Like I said, we just looked at 65 and up. We did have an EMR switch in October of last year from Athena to Epic. And so another, suggestion was that we can, use the new EMR system to our advantage and create automated MyChart reminders and things like that, that we did not have available to us with Athena. Larger sample size, also using, patients seen in clinic in the past 5 years versus just 1 year. And then lastly was evaluating pneumococcal rates prior to 2020. And that's when the approval for the PCV20 came about. So kind of looking further back before the new guidelines came about. And that is all I had. These were just our references.
And our thanks to you, Dr. Asadullah. At this time, Dr. Reese and Dr. Montgomery, if you have any questions, you can unmute and pose those questions.
This is Dr. Montgomery. I want to say thank you. Really interesting, I think, setup for a QI project. I wanted to ask, how long was the time interval between when you did your baseline data set in intervention and then your follow-up data set to see how the vaccine rate had improved?
That's a good question. So I'm trying to think back. We gave the talk May, so it was about, I would say about 6 months, 6 to 9 months.
Oh, wow. Okay. Yeah, that's a fair amount of time. Do you think, yeah, potentially may have seen, and you did the presentation one time or multiple times?
It was just one time. Yeah.
Okay. Yeah, I wonder if maybe having repeated that at, maybe somewhere in between there at like 3 months or 4 months, just to kind of refresh people's memory. I wonder, would be curious to see if that improves your rate even further, but yeah. Great project.
Thank you. Yeah.
Hi, this is Dr. Reese. I was also wondering if you were able to employ kind of the nurses in terms of your noon conference, and then if you were able to huddle prior to seeing patients to see, who might qualify for PCV20, and then increase rates that way.
Yeah, those are great suggestions. And we did kind of incorporate, now the nurses and MAs weren't all in attendance at our noon conference, discussion. But we did provide some physical handouts and things like that after our conference to the clinic staff. So they were aware that way. But I think, reiterating that and even, incorporating some of the huddle and, before patients came in would probably have also helped increase some vaccine rates.
Yeah, absolutely.
Mm-hmm.
Okay, hearing no further questions, our thanks to Dr. Asadullah for her presentation. We are at the halfway point of this final block. And with that, I would like to welcome on board. We have a new reviewer who's joined us, Dr. Connor Rhodes, and he's going to help out with our next presentation. So Dr. Lauren Lamb, if you want to unmute and share your screen, we'll see if, while your slides are coming up, I'll introduce Dr. Lauren Lamb out of the St. Louis University Southwest Illinois program. She's going to be presenting her in-progress research. And for your presentation, Dr. Sarah Reese will stick around. We'll welcome Dr. Rhodes to ask questions after you finish. I can see your slides. Let's see if we can hear you.
Yes, hi, I'm Dr. Lauren Lamb I'm a second year family medicine resident at St. Louis University, Southwest Illinois.
Okay, you sound great. So you have 15 minutes. I will give you a 2-minute warning in the chat if you hit that 2-minute mark. Otherwise, the clock begins when you begin your presentation, and we wish you good luck.
Thank you. So assessment is of PCA programming errors at a community teaching hospital is the title of my project. I worked with a colleague, Dr. James Bodko, who is also a second year resident in the program, our pharmacist, Dr. Jared Chile, and another pharmacist faculty, Dr. Christopher Herndon. So for background, effective and safe pain control is paramount in the hospital setting. And we had realized that there have been recently several gaps in analgesia due to divergence between the patient-controlled analgesia orders placed by the physicians and the staff physicians and us resident physicians and the actual programming of the PCA smart pump. And analgesia gaps or supertherapeutic opioid exposure are possible when pumps are misprogrammed. So the purpose of the study was to aim to compare PCA orders against PCA pump programming to describe the true error rate in terms of subtherapeutic or supertherapeutic opioid dosing. And that's just a picture of this is similar to the PCA pump that we use in our facility. So this was a prospective observational study. We had anticipated a power of 0.8 and an alpha of 0.05. So with a 1-to-1 ratio between our groups, which were going to be opioid naive versus opioid tolerant, for the orders, and incidence was of errors in opioid naive versus opioid tolerant. So we had anticipated having a study population of 200, 100 in each group to give us the power that we had wanted. The primary outcome measure was any divergence between the PCA order and the pump programming. The secondary outcome was discrepancies in bolus dose, basal rate, whether the patient was opioid naive or opioid tolerant at time of exposure, of the air exposure. And the inclusion criteria was all patients admitted to HSHS St. Elizabeth's Hospital with active PCA opioid orders, and exclusion criteria were persons less than 18 years of age at the time of the study and persons admitted to the hospital that were incarcerated. So for our results, we had a total number of 26 orders in 11 months of doing this study so far. 9 were opioid naive, 17 were opioid tolerant. The mean age was 54 for opioid naive and 48 for opioid tolerant. There were, for the racial and ethnic demographics, 3 patients self-identified as Black or African American, and 11 of the opioid tolerant identified as Black. 1 patient opioid naive group self-identified as white and Latinx, and 5 in the opioid naive identified as white non-Latinx compared to 6 in the opioid tolerant group. One thing that I'll mention is that from the 2020 census data, the proportions of self-identified on our census profile in Illinois for white non-Latinx was about 74%. For Black non-Latinx was about 13 or so %, and white Latinx was also around 6%, and 1% or so for Asian Pacific Islander. And we, in our study for the orders, there were no orders for anyone who I self-identified as Asian Pacific Islander or Latinx that was non-white. So that our demographics are a little bit skewed towards Black and white patient groups. There were females, 4 females in the opioid naive group and 13 in the opioid tolerant group, and 5 males and 4 males for opioid naive and opioid tolerant respectively. There were in the opioid naive group, all of the orders were correct. In the opioid tolerant group, 16 of the orders were correct. And 1 of the orders was incorrect. And it was an underdosing. So when going through our ICD-10 codes and our PCA order report, the Black opioid patient was admitted for a GI pathology non-malignant, which was a pneumoperitoneum. The 1 white non-Latinx opioid naive was for an abscess in the intra-abdominal abscess. For the Black opioid naive patient, there was a joint procedure, as well as the 1 of the white Latinx opioid naive patients and 4 of the white non-Latinx opioid naive patients. The one of the Black opioid naive patients had pancreatic cancer and was later transitioned to comfort care. And none of the opioid naive patients were admitted for sickle cell pain crisis. And then when going to the opioid tolerant group, there was no white Latinx patients in the opioid tolerant group, but all 11 were sickle cell pain crisis patients. And part of the reason our opioid tolerant did skew younger than the opioid naive was just the amount of young sickle cell pain patients that we had with PCA pumps during the time of the study. There was more variation in the ICD-10 codes for the white non-Latinx opioid tolerant group. 2 were for GI pathology that was not a malignancy, a chronic pancreatitis flare, and I believe another pneumoperitoneum. 2 were here for after joint procedures. 2 did have malignancies and were also transitioned to comfort care. And all of the Black opioid tolerant patients, I said, were sickle cell pain patients. So when comparing the home MMEs prior to their admission in the Black opioid tolerant versus the white non-Latinx opioid tolerant, you could see that there's much higher home MMEs for the Black opioid sickle cell patients that were in the 100 plus per day rate compared to their white counterparts, with mostly being 10 to 49 per day. And those were mostly among the total joint patients who've probably been on chronic opioids before getting either a joint replacement, and the 2, like the 50 to 100s as well, versus it was more the sickle cell patients having very high MMEs per day at home. So as I mentioned previously, all 11 of the opioid tolerant orders for Black patients were for sickle cell pain crisis. Of the 6 opioid tolerant PCA orders for white patients, they were, as I had stated previously, to malignancy, transition to comfort. 2 were after a joint procedure, 1 had pancreatitis, and the other had another GI concern. There was only 1 incorrect parameter out of 26 orders. It was a 39-year-old Black opioid tolerant patient admitted for a sickle cell pain crisis, and his parameters are underdosed. And as per our protocol, an IRIS report, that is our patient safety reporting tool that we have at our facility, was used to submit that error. And also the team that had admitted the patient were also informed. So one of the confounding issues is that while the subjects were the PCA orders themselves, the PCA orders are placed by people and the pumps are programmed by people, so you can't rule out any of the biases that you see with social determinants of health, especially with our large number of Black sickle cell pain crisis patients who probably had a lot of interactions, either good or bad, with the healthcare system. And you still have to, so for maybe there could be some racial ethnic bias there that was not there. Maybe they were seen as being more pain seeking and drug seeking just due to their high levels of pain, likely due to their having a high opioid tolerance and possibly some opioid induced hyperalgesia just due to their fact that they've been on chronic opioids for such a long time and at such high levels. Also, there were some multiple changes in orders as the study had proceeded for the subjects for the orders and not the patients. Then if there was any change in order, it generated a new subject in the report for that specific programming at that time. So there could have been some miscommunication resulting in underdosing or overdosing. And as mentioned previously, there could be some biases that affected the programming, whether they were underdose, overdose, whether the orders were changed or not. It just depends. And this is just from the Kaiser looking at social determinants of health. So limitations, as I had mentioned previously, we have a very small sample size, only 26 orders, and we had been hoping for 200. And so there's very poor generalizability, especially due to our demographic skew with having such a high number of Black patients just due to the sickle cell issue, as well as it being more Black and white and not having a large variety of ethnic groups. Further research is definitely needed, and we felt that the study should be repeated at a tertiary care center with a dedicated pain service and increased use of PCA smart pumps, as well as a more diverse patient population compared to our small community hospital. We had planned to do a secondary study based off of the hypothesis that there would likely be more errors in non-white patient orders compared to white, especially for those who are opioid tolerant, but we still have not reached the sample size that we wanted to achieve the power that we had desired with our current study. We've already had expanded our end time past June, and we're meeting that this coming month when it's supposed to be our end date at the end of June, because we had planned for a year of data collection if we would like to continue and expand and extend our data collection for another 6 months or another year, and then continue with the next class with collecting data for this, or if this is something that we should maybe just go in a different direction, or maybe see if we can reach out to some of our other larger facilities like SLU in St. Louis to see if they would help with adding more data to the study. Those are all things that we'll be discussing when our group next meets. And that concludes our presentation if there's any questions.
All right, thanks to you, Dr. Lamb. And yes, I imagine we do have some questions. So at this time, Dr. Rose or Dr. Reese, you can unmute and pose your question.
Hi, this is Dr. Rhodes. Yes, I have a couple questions for you. The first one is, you said that the opioid tolerant people with sickle cell pain crisis were on more than 100 equivalents of morphine per day. Was that on the PCA or was that prior to admission?
Oh, that was prior to admission. When we got the orders, we would go and investigate the pump, and part of it was asking the patient how they self-identified and asking whether they were opioid naive or tolerant. And if they had said, oh, I've been taking opioids before, then we asked them what their home dosing was. And we also compared it to what was in their medication list for admission. And then we calculated their MMEs based off of what they are on. So for our sickle cell pain crisis patients, the smallest was about 10 MMEs, and then the highest was 120 MMEs per day prior to their admission.
Thank you. Follow-up question, towards your summary, you said you'd like to see this repeated at a large academic institution. Do you think there would be value in repeating it in a number of smaller community hospitals and pooling data?
That may work if they have if they have a similar demographic makeup to us, that it probably wouldn't. We might have more numbers, but not so much the variety to make it more generalizable. And there are some small regional hospitals in our area, but we're one of the larger facilities, but that would be something to consider. And I will definitely bring that to our group when we have our meeting since the study is coming towards its anticipated endpoint date, but we will likely need to extend that.
Thank you.
And you know what? I made a mistake earlier on. It should be Dr. Montgomery, who is the second reviewer for this one. So Dr. Montgomery, if you have a question, Dr. Reese will hang on to you for the next presentation. I apologize for that.
No worries. This is Dr. Montgomery. Thank you, Dr. Lamb. What a really interesting project. My question is a little bit more around kind of, I guess, how did this come about? I mean, how did you become interested in this topic? Were you seeing a trend of PCAs not being programmed correctly, or what kind of sparked your interest in this work?
Yeah, so we had seen a trend of PCA pumps not being programmed correctly. We had, on our resident inpatient team, we do admit a lot of community patients, which are the sickle cell pain patients. And we noticed that our orders weren't actually matching what the patients actually had when we were going in the room and seeing them. So that's why we said, okay, we need to figure out why this keeps happening. Is there a trend happening here? And would maybe having more pharmacy intervention as we do round with the pharmacy team, like having a pharmacist review it when they're programming the pumps, maybe that would help reduce the errors. But there are a lot fewer errors, but also a lot fewer PCA pump orders than we had anticipated. So that was one of the things, making sure.
Yeah, right. I thought it was interesting, in 11 months to have, a total of 19 or 20 patients and only one error. Is that right?
Yeah, there are 26 total.
26, okay.
Yeah, and there were just one error. But the one error was what we had anticipated. It was an opioid tolerant patient that was Black. So I was like, I think that's
and
probably
underdosed, yeah.
and underdosed. So that's why I feel like I bet that's probably what's gonna happen. But yeah.
Do you think and then had your team started working with the pharmacist around the PCA pump ordering before, kind of at the time the project started, or at any point did that pharmacy involvement in the PCAs change during the course of the last 11 months?
No, at the beginning, we had formulated the protocol with our pharmacist because we round as a team. And so I had mentioned with Dr. Herndon, it's like, there's a lot of errors. And he's like, yeah. Then it's like, how about we come up with this? So then I wrote the protocol. I recruited my colleague, Dr. Bobko, who was able, because we rotate off and on for inpatient as well as other sites. And so when I wasn't available, he was able to collect the data. When he wasn't, I was able to collect the data. So we collect data for that whole time. But there were, as I said, there were months at a time where there were no PCA pumps. So it just sort of.
Yeah. I wonder if it would, I mean, you may have kind of like improved the outcome already just with the protocol, right? I wonder what it would look like if you went back and did like a retrospective chart review of the year prior before the protocol was in place, just to see if maybe there was like any difference kind of pre-protocol and post. Maybe not. Maybe there's still only 20 pumps a year.
Yeah, that would be interesting to see. I would have to talk with the pharmacist that I worked with to see if there's they keep track of it after the patient's already discharged. We can go back and look through it.
Yeah. Well, thanks for your hard work. It's interesting for sure.
Thank you very much.
All right. Hearing no further questions, we give our thanks to Dr. Lamb for your presentation. And we have our 10th presentation of the day. If Dr. Mir Manan Ali Hashmi would go ahead and unmute and start calling up your slides. Dr. Hashmi joins us from the Mount Sinai Jackson Park Family Medicine Residency Program in Chicago and has a completed project to share with us today. Just to make sure, Dr. Connor Rhodes and Dr. Sarah Reese, please stay on board to review this presentation and have some questions ready at the end. Okay, we see your slide. Let's make sure we can hear you.
Good afternoon, everyone. My name is.
I do hear you. Okay, just to review, you have 15 minutes. I will start the clock when you begin, and I'll give you a 2-minute warning in the chat if you get to that point. And then otherwise, the floor will be yours and the reviewers will be watching and have questions for you. So thanks for being here and good luck to you.
Sure, thank you so much. Good afternoon, everyone. My name is Manan Hashmi. I'm a third-year resident from Jackson Park Hospital. Today, my topic of presentation is Unraveling Cannabinoid Hyperemesis Syndrome, Insights from a Community Hospital Cohort Study. So just a basic overview of the study. Cannabis is widely recognized as one of the most commonly used psychoactive substances globally and is raising concerns due to its increasing potency and the emergence of associated adverse effects, particularly cannabinoid hyperemesis syndrome. CHS, marked by recurrent episodes of severe nausea, vomiting, and abdominal pain among chronic cannabis consumers, requires a deeper investigation and remains a diagnosis of exclusion. This retrospective cohort study examines data from 50 patients aged 18 to 75 presenting at the emergency room of a community hospital in Chicago's South Side over 3 years. These patients were experiencing upper GI symptoms, mainly nausea, vomiting, and abdominal pain, and were tested positive for cannabis use. Among them, 34 were diagnosed with CHS, manifesting cyclic nausea and vomiting. Methods used utilizing a quasi-experimental design. The study compares patients with cannabis use and upper GI symptoms to those who were diagnosed with CHS. Diagnosis follows ROM-4 guidelines considering symptoms, cannabis use duration, and cessation leading to relief. So some introduction and literature about CHS. Cannabis is a widely prevalent psychoactive substance known for its addictive properties and extensively used across the globe. As per WHO reports, about 2.5% of the global population, that is about 143 million people, indulges in cannabis consumption. Cannabis use is associated with acute and long-term physical and mental adverse effects, including anxiety, impaired coordination and performance, hyperemesis syndrome, psychoactive disorders, mood disorders, respiratory and cardiovascular disorders, and many other diseases. Among these adverse health effects, cannabinoid hyperemesis syndrome emerges as a newly recognized medical condition with a growing incidence among the cannabis users. The prevalence of CHS is reported as 32.9% in an urban public hospital in the United States. CHS tends to manifest more prominently in men and presents as recurrent episodes of severe nausea, vomiting, and abdominal discomfort without any organic cause, particularly among individuals with a history of long-term cannabis usage. The diagnostic framework provided by the ROM-4 criteria, specializing in GI disorders, offers a comprehensive guidelines for recognizing CHS. As outlined in these criteria, CHS is characterized by prolonged cannabis consumption, recurrent bouts of nausea and vomiting, and resolution of symptoms upon cessation of cannabis use. Alternative diagnostic guidelines propose that the relief of cyclic nausea and vomiting through hot baths and showers among individuals with a history of daily cannabis use exceeding 1 year is pathognomonic of CHS. CHS is particularly significant due to its unknown mechanism and pathophysiology. While cannabinoid compounds are widely recognized for their antiemetic effects, CHS presents a paradox, contraindicating the marijuana's typical pharmacological response. Prolonged cannabis use opposes its antiemetic benefits, leading to cyclic episodes of hyperemesis. One proposed mechanism suggests that prolonged and excessive administration of cannabinoids disrupts the normal functioning of the endocannabinoid system by influencing the CB1 receptor. However, the precise mechanism underlying CHS remains unrecognized despite its clinical manifestations necessitating further investigation. The best way to treat CHS is to stop using cannabis completely. Taking hot showers or baths can help relieve symptoms in the short term. Pharmacological treatment has a limited role in the treatment. However, some of the recommended pharmacological treatment options with variable efficacy include the use of tricyclic antidepressants, lorazepam, ondansetron, promethazine, diphenhydramine, haloperidol, metoclopramide, and capsaicin. CHS often goes unnoticed because its symptoms can look like those of other stomach problems. Therefore, the disease should be considered as a differential diagnosis in patients with a history of cannabis use to avoid diagnostic workup scans that might not be needed. Despite the rising prevalence of cannabis consumption worldwide, our understanding of CHS remains limited because of lack of comprehensive studies, particularly in community hospital settings. Our research tries to fill this gap by looking closely at CHS in a community hospital setting. We want to understand its science, how it's diagnosed, and how it is treated in this setting. By doing this, we hope to learn important things about CHS that can help improvise the treatment and help policymakers make better health decisions. So coming to aims and objectives, the primary aim of this study was to examine the possible correlation between CHS and cannabis use within a cohort comprising patients. Furthermore, additional outcome measures were delineated to investigate and potential connections between patients being diagnosed with CHS, particularly in relation to the first is the relationship between cannabis use plus upper GI symptoms and to the patients diagnosed with CHS. The other objective is to find out the association between diagnosis with CHS and other variables, including gender, age, and BMI. Selection of patients. This retrospective cohort study examines data collected from 50 patients ranging in age from 18 to 75 years who sought treatment at an emergency room of a community hospital on Chicago's South Side over 3 years. These individuals presented with upper GI symptoms and tested positive for cannabis use. Within this cohort, 34 patients were specifically diagnosed with CHS, demonstrating cyclic patterns of nausea, vomiting consistent with the Rome 4 criteria. Conversely, 16 patients reported cannabis use but did not meet the Rome 4 criteria. So EHR data was reviewed for patient selection who had documented GI symptoms and reported cannabis use within the timeframe spanning from January 2021 to December 2023 at Jackson Park Hospital emergency room. Supplementary patient identification was conducted based on diagnosis codes incorporating search terms such as cannabinoid hyperemesis syndrome, cyclical vomiting syndrome, then cyclic vomiting syndrome with unspecified presence of nausea, and a few other related codes. Coming to statistical analysis, data extracted from EMR system hosted at the community hospital was exported to an Excel spreadsheet for a subsequent analysis. The analysis was performed using the AI model Scholar GPT using the Python software, which provided outcomes and schematics. A comprehensive summary table was generated from the spreadsheet data, delineating the continuous variables in the data set, that is age, length of stay, BMI, as well as the categorical variables like gender, the cannabis use, and the diagnosis of CHS. Statistical analysis, including chi-square test and correlation coefficient analysis, were employed to evaluate the association outcomes among different variable sets within the data set. So coming to results, this table shows the descriptive summary for categorical variables. So all the patients, that is total number of 50 patients, were positive for cannabis use, and they also had upper GI symptoms. And those diagnosed with CHS were 34. Those who didn't meet the criteria for CHS were 16. Out of them, females were 33, accounting to about 66%, and males were 17. Now coming to the continuous variables, that is age, length of stay, and BMI. The mean age was 35.4, whereas mean length of stay was 1.42, and mean BMI was 26.31. And we also have distribution based on percentile. Baseline characteristics are outlined in the tables 1 and 2 based on the analysis of a data set comprising of 50 patients. The chi-square test results in a p-value of 1, which suggests that there is no statistically significant association between cannabis users with upper GI symptoms and the diagnosis of CHS. This indicates that within the data set, having upper GI symptoms while using cannabis does not appear to be related to whether a patient is diagnosed with CHS. Correlation analysis was conducted to assess the relationship between those who were diagnosed with cannabis hyperemesis syndrome and age, resulting in a correlation coefficient of 0.008. This very low correlation suggests almost no linear relationship between age and the diagnosis of CHS. Similarly, the association between association between those who were diagnosed with cannabinoid hyperemesis syndrome and gender yielded a chi-square statistic of 0 and a p-value of 1. This indicates no significant association between CHS diagnosis and gender. Furthermore, the correlation between those who were diagnosed with CHS and BMI revealed a correlation coefficient of 0.202. This indicates a weak positive correlation between BMI and the diagnosis of CHS based on Rome 4 criteria, suggesting that as BMI increases, there is a slightly higher likelihood of meeting the CHS criteria, although the relationship is not strong. Coming to the discussion, the results suggest a lack of significant association between cannabis use and upper GI symptoms, and between with those diagnosed with CHS based on the provided data. This implies that regardless of whether a patient meets the Rome 4 criteria for CHS, their patterns of cannabis use do not exhibit statistically significant variations, indicating that cannabis consumption alone may not be a distinguishing factor in the diagnosis of CHS. This suggests that factors beyond cannabis use may contribute to the development of CHS. Our analysis revealed no significant association between CHS diagnosis and gender. This finding implies that CHS does not exhibit a gender-based predilection. However, a study has shown that CHS is more commonly diagnosed in adolescent females, often attributed to a history of underlying anxiety or depression. On the contrary, some argue that CHS is more prevalent in males due to higher rates of cannabis use. Moreover, the correlation analysis demonstrated almost no linear relationship between age and the diagnosis of CHS. This suggests that age may not be a determining factor in the manifestation of CHS, underscoring the multifactorial nature of the syndrome. Interestingly, a weak positive correlation was observed between BMI and the diagnosis of CHS. While this correlation is not strong, it suggests that individuals with higher BMI may have a slightly increased likelihood of meeting the diagnostic criteria for CHS. This finding warrants further investigation into the potential mechanisms underlying the relationship between BMI and CHS. Overall, our research highlights the complexity of CHS and underscores the importance of considering multiple demographic and clinical factors in its diagnosis and management. Future studies may benefit from exploring additional variables and revealing underlying mechanisms contributing to the development of CHS, ultimately enhancing our understanding and management of this syndrome. However, it is crucial to acknowledge the limitations of the available sample size, which may hinder the derivation of definitive conclusions. Therefore, further exploration with larger data sets is suggested to validate these findings comprehensively. Nevertheless, our analysis revealed a positive correlation between BMI and CHS, suggesting a potential avenue for future research and clinical consideration. In conclusion, our research reveals a fine understanding of cannabis use with upper GI symptoms and cannabinoid hyperemesis syndrome and its association with gender, age, and BMI. While cannabis use alone may not fully explain CHS diagnosis, our findings underscore its multifactorial nature. Contrary to some previous studies, we found no significant age or gender-based predilection for CHS, though conflicting reports exist in the literature. A weak positive correlation between BMI and CHS diagnosis suggests a potential avenue for further investigation. Further investigation is essential to elucidate the underlying mechanisms and optimize management strategies for CHS. These are my references. And my mentor is Dr. Dharam Dasani, who is a faculty in family medicine at Jackson Park Hospital. And I have some of the co-authors, Dr. Muhammad Khan, who is MBBS and Master's in Clinical Research. And I have a couple of medical students, Zachary Blask and Catherine Blask. And thank you.
And we thank you as well. And now our two reviewers, Dr. Rhodes and Dr. Reese, the floor is yours if you'd like to unmute and ask a couple questions of Dr. Hashmi.
Hi, Dr. Hashmi. Great presentation. This is Dr. Reese. My question was, I know that you looked at gender and BMI, but did you by any chance come across any dose dependence as well as frequency of marijuana use and its correlation with being, diagnosed with CHS and GI symptoms or otherwise?
So Since this was a retrospective study and it was mostly based on the data, I couldn't find out like the quantity, the frequency, or the amount of marijuana that was being used. So yeah, I couldn't find out that thing. It was difficult. I mean, I could find out in some patients, but it wasn't there for everyone. So I had to exclude that.
Okay. Thank you.
Hi, this is Dr. Rhodes. Thank you, Dr. Hashmi. You threw a lot of information at us really fast, which was kind of interesting and sort of contradicted a lot of the things I thought I knew about hyperemesis syndrome with cannabis users. And so I appreciate your work. And
thank you, Dr.
So other than doing it on a larger scale, what do you think the next steps are?
I think larger scale is the first thing. And then we can also look into other factors like patients who have any kidney problems or not, if that is affecting, or since this study was based on the patients at south side of Chicago, so demographics can also play a role. We can look into that aspect as well.
Thank you.
Yep.
Look for my comments when you get our evaluations. I have some comments for you that I don't want to say here.
Sure. Thank you so much, Dr. Rose.
And our thanks to Dr. Hashmi and both of our reviewers. And believe it or not, that brings us to the final presentation of this year's summit. Amazing that we're running a couple minutes ahead of schedule. There's never a bad thing when you get a couple minutes back into your busy day. So with that, we're going to head back to Southwest Illinois and welcome Dr. Harathi Bouma, also from the St. Louis University Southwest Illinois Family Medicine Residency Program, our final presenter of the day. She's going to do her completed project. And once again, for this final presentation, we'll welcome back Dr. Addison Montgomery and Dr. Connor Rhodes to bring this ship home. Dr. Bouma, if you can unmute and start sharing your screen, we'll make sure we can hear you and see your slides. And while you're doing that, I'll remind you that you will have 15 minutes once you start. When you get down to 2 minutes, I'll put a little 2-minute warning in the chat box for you. And then at the conclusion of your presentation, Dr. Montgomery and Dr. Rhodes will have a few questions for you based on your presentation. I can see your slides. Let's make sure we can hear you.
Sure.
We sure can.
Hello, everyone. Can you? I guess
Okay.
Yep.
Good luck to you. The presentation will begin when you do.
Yeah. So this is a retrospective study I did with one of the my attending, Dr. G. He's a neurologist. So the clinical effectiveness of rimipigant with addition to the botulinum toxin type A in treatment of chronic migraine. So the objective is to describe this, as I said, like to describe the clinical effectiveness of the rimipigant as an add-on medication to the toxin A for treatment of chronic migraine. Usually, the rimipigant is used as an acute migraine medication to prevent the acute migraine, not the like curative treatment for the acute migraine. But we did some studies, maybe what's the effectiveness of for the chronic migraine. So as we know, like rimipigant is a CGRP receptor antagonist, and currently I mentioned as in acute migraines for the preventive treatment of episodic migraines as well. But there is usually what we heard, like there is no real study combination of the rimipigant on the top of that botulinum toxin type A. So we did some study. It's a retrospective study with 10 female Caucasian patients, and who is as they were well aware of that medication, so who received 3 bounds of Botox and but then started on the rimipigant. So we initially started with the Botox, and after the addition of the 3 rounds of the Botox, we added at 1 month, 3 months, and 6 months. It's not at 1 month, like one month period, then 3 months and 6 months, and tracking that monthly migraine days. And seeing like how many monthly migraine days. The p-value is usually less than 0.05 and which we consider as statistically significant. So this is the data we had. Let me use my laser. So this is the serial numbers. We had the 10 Caucasian females and mostly age around like maybe 20s to max of 50s. And this is the monthly migraine days before Botox. And this is the study like after the 3 rounds of Botox. And after the 3 rounds of Botox, we added the new tech every other day for a month. And usually the monthly migraine days, you can see the nicely decline in monthly migraine days. So after the 3 months of every other day new tech, it came up to 6. And the 6 months after that, the nice decline in 4. From initially, it's before like 18 to 4. I'm just giving you an example. And otherwise, the side effects is mostly nothing, most like just the dyspepsia and nausea, but most of the patient doesn't experience any side effects. But few patients have some using some other migraine medication as needed, but not on a daily basis. And this is the histogram view, and you can see this nice decline. This is the monthly migraine days before it starting of any medication, the blue columns, and the declining status of the monthly migraine days after the starting of the rimipigent after 6 months. You can see that. And this is the other way of the different histogram the other way, and with this orange like monthly migraine days of the 3 days, usually it's this nice decline from 20 and 25 to around 5, and here, like I say, it's the 6 months after the new tech is declined, like in this patient, like maybe less than 1. And this is other ways, like showing the monthly migraine days, decline in the monthly migraine days. The blue thing is the before Botox, and with Botox 1 month, and with the 3 months, sorry, with 1 month, with 3 rounds of Botox, and with 1 month of new tech, 3 months and 6 months of new tech. So usually the results, the mean age, usually as mentioned, like it's the range from 20 to 50 years, and it's usually the range is 34.6 years. And the monthly migraine days after the 3 rounds of treatment was 19, initially was 19.8, and with 95% confidence interval, which declined to 11.8 days with 95% confidence interval. This is with Botox and after 3 rounds of treatment. And the monthly migraine days after 1 month and 3 months and 6 months of the new tech was kind of initially like 19.8 to 7.9, and with 4.7 days and 4 days with 95% confidence interval. So all the p-value being statistically significant. So the overall impression is 80% improvement of the mean monthly migraine days after 6 months, and as mentioned, there is 80% of patients with no side effects, just the nausea and dyspepsia, but 50% was patients was on other migraine medications as needed. So the conclusion is, I know this is a quick presentation. The conclusion is this study provides the evidence of significant benefits of the rimipigent and addition on top of the Botox, 3 rounds of Botox, and who is already on Botox, and the decline in the chronic migraine, monthly migraine days in chronic migraines. And I'm happy to take any questions.
Well, thank you so much, Dr. Bouma. And at this time, our 2 reviewers, Dr. Montgomery and Dr. Rhodes, the floor is yours.
Hi, this is Dr. Rhodes. Thank you, Dr. Bouma.
Hi, Dr. Rhodes.
Unlike the previous presenter, you presented me with very little data. So let me ask you some questions about your funding and data. And so you use brand names sometimes and use generic names sometimes. Was there any industry sponsorship of this study?
Not really, sir. It's usually like because the patient, Dr. G, is well known, that only neurologist in our town. So he's well known for neurology, and usually patients are well aware of that. And he's good at research. So there is no funding with any companies or any like NoTech or Remipigent. It's usually like patients are well aware of that, and we want to try, like, see how it does, and it's completely our own thought process.
So you picked 10 patients here. Was that during a certain time frame, or did you start out just saying we want to pick the next 10 patients? How'd you pick those 10 people?
Yeah, it usually like we usually have the paper who like a paper survey who are interested in research. So we collected the data. I would say maybe 6 to 8 months, and who are interested, and we thought like 10 people, we can go with the 10 people, and I mean those people, like as mentioned, like we asked them to fill out a form, is interested in research or not. And whoever like interested, we gathered that people, and we thought like as 10 people, we can go ahead and do our studies.
So these were just the first people that agreed to the study and signed up for it.
Yes, sir. Yes, sir.
Thank you very much.
Thank you, Dr. Rhodes. Appreciate.
Hi, Dr. Buma. This is Dr. Montgomery. Thank you for your presentation. I wonder, I mean, it's a pretty impressive decrease from where the patient started before Botox until after 6 months of Nurtec. I wonder, did you also break out the data based on kind of like the interval % improvement? So I wonder, like, what was the improvement from pre-Botox to post-Botox, and then from, you know, month 1, month 3, month 6? Because looking at the graphs, it looks like you do continue to have improvement, but that kind of levels off at a certain point. The biggest jump seems to be from like pre-Botox to post-Botox. So I wonder, kind of breaking that data out, if you might see, you know, that Botox kind of does the heavy lift, and then what % improvement do you get after that with just adding on the Nurtec? Does that make sense?
Yes, yes, definitely. Yeah, I do agree. As mentioned, like usually it like we calculate the monthly migraine days. So the initially the monthly migraine days was from 9, usually like it started around 19 monthly migraine days per month, and with Botox it decreased to 11.8. But with the new tech, it definitely like decreased to single digit. That's why like in 7 days and 4 days, and ultimately the 4 days, like yeah, this is the one I was looking for. Sorry. So,
yeah, so my
sorry.
No, go ahead. Go ahead.
So yeah, before Botox, before Botox is 18. Like if you, I'll go with the serial number 2, like 21, and with Botox it's definitely 14, and with the new tech, just a 10, and big study. I mean, I would say like maybe the single digits. Most of them are single digits. Before the Botox, even though after Botox there are two digits, and after starting the Remipigent, it's kind of single digits. So I think it's I'm not sure how much %, but I would say like pretty much decreased in monthly migraine days to a single number there.
Oh, for sure. Yeah. And it might be interesting to tell patients too, if you have patients that have Botox and then want to say like, okay, but we know that we can get your symptoms under even better control. So if we say Botox takes us from, can you go back to the summary, data summary slide?
Sure.
So if we say, you know, if you have before Botox, you're at an average of 20, let's say, and then you get down to 12. So that's an improvement of, oh my gosh, math is hard. Let's see.
Yeah.
12 divided by 20 is about 60% improvement, right? And so then from there, you can say, if we add on the Nurtec after 6 months, we would get maybe an additional, so from 12 to 4. So maybe an additional 30% improvement, something like that. It might be a way to kind of talk to the patients about like, look, we can get your symptoms down by this much. Adding on the Nurtec is going to give us this much more, just as a way to kind of frame it for patients to understand, well, if I did this, why do I want to take this other pill also?
Yep.
But yeah, really interesting. Thank you.
Yep. Yeah, thank you. Thank you, Dr. Monoway.
Any further questions for our final presenter of the day? All right, well, hearing none, I'm going to do a little wrapping up here for everyone. Move the spotlight there. And so here's how this works. Thank you to all the research minds and colleagues and collaborators who put together 11 presentations for us today. And thank you to the 8 faculty physicians who volunteered their time to serve as reviewers. So those scores and comments will be submitted online by our reviewers the rest of the day. I'll be spending time tomorrow crunching numbers and merging their comments, and I will send the scores and comments directly to the lead presenter of each submission at some point tomorrow, and also a link to the recording, so you'll be able to see that. The highest scoring category in our completed projects and research in progress categories will get an Amazon gift card that will be an electronic gift card sent to the lead presenter. And then the recording of this entire presentation will be posted on the IAFP's website. Again, don't forget, if you are going to submit for CME credit, which all of our reviewers and any other faculty physicians should do so, there's the link in the chat. And all of our presenters, please consider submitting your research as an abstract for Family Medicine Midwest. That call for abstracts is open till June 2nd, and that would do it for us today. We appreciate everyone who participated. I hope you have a wonderful afternoon, and thank you for joining us.